to the inaugural session of Second International CME on Viral Hepatitis. It is our privilege to have amongst us Professor Dr. Colonel C.D.S. Katoch, Executive Director, AIMS Rajkot, as the Chief Guest for the CME. Sir has been the pillar of support for all our endeavors, and he deeply values the CME. So we welcome you, sir, and thank you so much for spending your valuable time. Before we begin our CME, we have the honor of partaking in a time-honored tradition, the lamp lighting ceremony. Knowledge is a lasting inner treasure which adorns the mind by the light of wisdom. Just as the brilliance of light does not diminish, so do the knowledge when shared with others. Hence, we light the lamp to go down to knowledge as the greatest of all forms of wealth. We shall now commence our inaugural session by invocation of Goddess Saraswati and lighting the traditional lamp. I invite Executive Director Sir on stage to light the lamp and officially inaugurate our event. I also request Dr. Sanjay, Dean Academics, Dr. Simi Mehra, Dean Examination, and Dr. Alpini Agarwal, Organizing Chairperson for the CME, to please join the Executive Director Sir on stage and do the honors. Thank you, respected dignitaries. I request you all to please take your seats. We shall now have the inaugural address by Professor Dr. Colonel C.D.S. Katoch, Executive Director, AIMS Rajkot. Professor Katoch superannuated from Army Medical Corps in July 2020 after 34 years of glorious service for the nation. Served as Professor and Head of Department of Pulmonary, Critical Care and Sleep Medicine at Army Institute of Cardiothoracic Sciences, AFMC Pune. As a clinician, bedside skills and pulmonary interventions are very close to his heart, and he has a passion for research and academics. Sir has always adopted a human approach while dealing with medical and administrative issues. It's this approach which makes Sir very popular among his students and patients. I request you, sir, to please deliver the inaugural address.
Good afternoon to all of you, and thank you so much for trying to the meeting. First of all, I compliment the Department of Clinical Microbiology and Infectious Diseases for this very, very apt and often neglected topic. The text of Hepatitis A, we could not align with that, but we choose today to have this program. I welcome you all, whoever is present here physically, and I think more than 1,300 registrations have been done from our country and from abroad. there's a matter of pride that whenever this department has published advertisement for the CME, a lot of people have gone through it. So it's a matter of pride for all of us and our institute. I remember the same department organized a CME on infectious viral hepatitis last year. And last year we were on, I think, the total virtual mode. This time we have learned up into hybrid mode. And I hope that next year we will have a physical full scale CME on such an important topic. You know, the hepatitis B proactively diagnosed when the patient present to us with jaundice. And the statistics says it kills as number of patients as humans. We have an NPP program, our tuberculosis eradication by 2025, the national program. 2030, but this is one of the neglected area and which is taking a toll of people because of ignorance on part of patients as well as on part of doctors. So today's CME will remind us that we have to be proactive in diagnosing these type of patients and timely intervention. Today we have hepatitis B preventive program and the vaccine. So far this vaccine is limited to only people, healthcare workers and all those who are exposed to patients and all, but we have to bring out the awareness that all of us outside who are not even healthcare workers, they should also undergo this vaccination because this is one of the preventable diseases. The other important virus is the hepatitis C. We have a treatment for hepatitis C. A lot of check and balances have been put into place in last decade. As we know, hepatitis C is usually because of transfusion and this thing. But there is a cure. In today's date, there is a cure for hepatitis C virus. So the one is preventable, one is curable. The only thing is, even somebody is infected with this virus, may not manifest physically, and that's the reason they don't seek the mental health and they remain undiagnosed and subsequently time they land up with chronicity of liver disease. That is the time they are diagnosed, but that's too late. And we sensitize ourselves. We have, you know, the slogan for World Hepatitis Day for 2024 is time for action. It's indeed a time for action for all of us that we go for preventing, promoting, and curative treatment of infectious hepatitis. As I said, the deaths viral hepatitis are comparable to tuberculosis. But the catch is, most of tuberculosis patients have access to the treatment because they are diagnosed. But in viral hepatitis, most of the patients, they don't have access to treatment. In B, we don't have treatment. In C, we have a treatment, but by the time they diagnose the disease, they are already progressed. So we have to sensitize others, ourselves, that like tuberculosis, we have to intervene and take this challenge along so that our communities are prevented from all this. Today, I extend my heartfelt gratitude to our two esteemed speakers. They don't need much description because they themselves are the giants in their own academic field. One is Professor Dr. P. Arnain from CMC Bellour, and the other one is Professor Dr. Ekta Gupta from ILBS New Delhi. So both of them, they have excelled and they are the known figures in their own field. It will be our privilege to listen to them and have them with us and carry their words of wisdom to our society. I am particularly delighted to see the response to this CME. Over 1,300 registration from India and across the globe. This reflects the global recognition of the importance of our collective effort in addressing viral hepatitis and the efforts put up by the per se on behalf of all. As we embark on today's session, I encourage each one of you to actively engage, ask questions, share your experiences. Let's make the most opportunity to learn from the best minds of the field which we have. Professor Ashti himself is very much involved. This topic is heard. And we have chosen two dignitaries, giants in the same field as enumerated. And thank you, Dr. Priya, and thank you, Dr. Ekta. If you are listening to us, I am grateful to you for sparing your time. Thank you so much.
We extend our heartfelt thanks to our Executive Director, Sir, for his inspiring words. We are truly privileged to have had the opportunity to hear your thoughts and insights. Thank you once again, Sir, for joining us. We shall now begin with today's deliberation. Over the next 2.5 hours, we have experts from the field deliberating on the current status of viral hepatitis, the progress and achievements in our fight against the disease, and gaps and needs in our efforts to eliminate the disease as a public health concern. Delegates may pose their queries in the chat box. We will try to address them at the end of the session. In case we are unable to take the questions today due to paucity of time, we will surely revert you back via email. So, without further ado, I request Dr. Ashwini Agarwal to deliver the opening address on India's roadmap for elimination of viral hepatitis by 2030. Sir is an alumnus of the prestigious Armed Forces Medical College, Pune. Sir has served in the Army for more than 25 years, during which he was posted in leading tertiary care hospitals and teaching institutes of the armed forces. Sir was a professor in microbiology at his alma mater before he decided to hang up his uniform. Dr. Agarwal is a passionate teacher and diligent researcher. Currently, Sir is working as a Dean Research and Professor in Head Department of Clinical Microbiology and Infectious Diseases at AIMS Rajkot. Sir is Principal Investigator for VRDL and BSL-3. Over to you, Sir, Dr. Ashwini Agarwal.
Good afternoon, everyone. Thank you, Dr. Bhumika. Okay, at the outset, I would like to thank our Executive Director, sir, for giving us this opportunity. This is the second time in a row on World Hepatitis Day for organizing this event. I would also like to extend my heartfelt thanks to all the speakers and all the by 2030 is a very ambitious goal. So over next few minutes, we will see whether it is possible, whether we are on the right track, and if not, then what action should we take to get back on that track. Hepatitis, as we all know, is caused by these five viruses named A to E, of which HAV and HEV are transmitted by fecal route and they generally cause acute hepatitis. So we generally don't worry more about that when we talk about aluminum. More concern are hepatitis B and C, which tend to cause chronic disease, and they are transmitted by parental route. Hepatitis B is rarely present in India. Hepatitis B and C, since they lead to chronic hepatitis, once chronicity sets in, then after a period of 2 to 3 decades, of serious complications like chronic hepatitis develop, we can progress further into cirrhosis and hepatocellular carcinoma, end-stage liver disease, and finally to death. So this is the main cause of mortality due to hepatitis, and this is the area which we are focusing when we are talking about elimination. So WHO recently released its global hepatitis report, in which hepatitis has emerged as number 2. It was only below COVID-19 as far as mortality is concerned. So TB and hepatitis both killed equal number of people. Second only to COVID, and now COVID is no more a concern, so hepatitis probably can come to number 1. And what is also worrisome is that this mortality is increasing. If you see the figure of 2019 and 2022, the mortality is increasing. A large number of people get infected daily, around 6,000 people as per the WHO estimate, and so it is a public health concern. So the first question which comes to our mind like TB is it really possible to eliminate it? If we say theoretically, yes. It is a disease which requires only humans. That is, humans are the only host, there is no intermediate host, and the virus also does not propagate in the environment. So humans are required for its life cycle. Mode of transmission is parental, and it is comparatively easier to control it because we can screen the blood. We have got very good diagnostic tests, and we can screen our patient. We can screen the population and prevent the transmission. There is a long latent period between infection and disease. So this gives a large window to take action. Unlike COVID, once you acquire the disease and the very over next few days, you are either okay. You are seriously ill. It is somewhere similar to smallpox and lesser than polio and measles, the disease which we have already controlled or eliminated. Also, there is effective interventions are available. For HCV, there is very good direct acting antiviral medicines. Presently, our program is focusing on pan-genomic DAAs, that is directly acting antivirals. And it used to be considered that we used to do genotyping, and then, but now we have changed to pan-genomic DAAs. So our next speaker, Dr. Priya, will be deliberating more on this. There is no hepatitis B C vaccine as yet. As far as hepatitis B is concerned, there is no virological cure. We cannot cure the patient, but we can treat the patient. Patient will require lifelong treatment to control the viral replication so that transmission can be stopped and also the serious complication can be checked. But there is a very effective vaccine available for HPV, which prevents in more than 95% of cases. So most of the focus is on this vaccine. The present data suggests that all HPV, maximum number of HPV infections are occurring because of the vertical mother to child transmission or anyone acquiring during the early childhood from their siblings or from their neighbors. So this is the main mode of transmission. We have got very good blood banking services. So by blood and other products, it is comparatively less. injury, yes, it is also one of the cause, but still we have got good hospital infection control practices. So vertical mother to child transmission is the main mode. And if anyone acquires the hepatitis infection early in life, there are more chances of developing it into chronicity. If neonate acquires it, it is around 9%. From 1 to 4 years, it is 30%, and if an adult acquires infection, it is less than 5%. So neonates are the one which can be most affected, and when they will reach their young age, 30, 40 years, at that time serious sequelae will occur. So antenatal care, screening of hepatitis B infection is required, and if found positive, mother can be given antiviral prophylaxis, and infant can be given hepatitis B immunoglobulin as well as the vaccine. So timely first dose and early childhood and adult vaccination can check the hepatitis B infection. Next slide number. So yes, theoretically it is possible, and this was realized by UN, closed by WHO in their global health strategy, in which they wrote out this allocation plan, in which they planned that 90% reduction in hepatitis B and C cases, and around 65% reduction in around 30% reduction in mortality by 2030. India also came up with their National Viral Hepatitis Control Program in 2018, which provides free screening, diagnosis, counseling services, and treatment services for hepatitis B and C to all patients free of cost. And it aimed at elimination of hepatitis C by 2030. Very next year, 2019, we came up with National Action Plan that how should we do it. So some strategies were suggested, they were implemented. But soon after implementation, it faced many challenges. And the biggest challenge was COVID-19, which came in early 2020, because of which all the hepatitis programs took a backseat. Also, to start with, we had a very limited data available with us. So the plan which requires any plan requires reliable data. Later on, many serological surveys were conducted, and it was realized that there are pockets of hyper-endemicity, many tribal areas, many villages. They have got prevalence as high as 60 to 70% of hepatitis B. Immunization coverage was low, and awareness among the population was very low. Not only general population, even healthcare personnel and politicians who are making our policies, they didn't do anything about hepatitis. So almost 90% of people, even if they had viral hepatitis, they didn't do anything about it. As we know that our all this health program they are taken up by state. So in different states took it in different ways, and the implementation was not uniform. Many states took it in a multi-tier system, and because of this multi-tier system, many of the services, especially referral services like pre-viral load, they were available only in the referral area, which were located in the capitals of the state. Supported and pre-treatment investigations were also not free. So access to preventive and treatment services was a challenge. Similarly, treatment also, there was a different tier system, and patient had to go from higher treatment to higher treatment. Also, the patients who are put on therapy, Compliance to therapy was a problem. 15% of patients report despite pre-treatment. And for hepatitis B virus, what existing guidelines we have adopted, or 8 out of 10 people, they remain ineligible to receive treatment. So there is a need to change this approach. We have to do something like HCV, that we should treat all patients who are HPV positive, so that at least transmission can be stopped. For HCV, if anybody takes on treatment, there is limited armamentarium available in the program. There was management cost for complicated case was also not included in the program. There was no provision of liver transplants in the program, and involvement of private sector was very limited. So what was the progress made during last 5 years? If you see, according to again coming back to WHO global health report, global hepatitis reports, India is still among the countries bearing the 2/3 of global burden. In fact, we are at number 2, having more than 11.5% cases of hepatitis B and C. Total around 3.5 crores cases of hepatitis B and C are presented in India, and around 1.3 lakh deaths occur annually because of this. When we talk of the access to diagnosis and treatment, for hepatitis B, diagnosis coverage was just 2.5%, 2.4% of estimated cases, and treatment coverage was almost nil. As per report, it was 0%. And for hepatitis C, because this was the main target in NHBCP, diagnostic coverage was 28% and treatment coverage was 21%, which is also much below our target. This is despite the fact that cheapest medicines and diagnostics are available in India. You can see the diagnostic price, if you compare it with the world over, then we have got the cheapest diagnostic available thanks to Medicaid campaign. Next one. And similarly, if we compare the cost of medicine for hepatitis treatment, again, India is in top 2, that is after China, India has the cheapest medicine. And also, large number of generic viral hepatitis medicine are available in India. And because of this, we can give our patients a very treatment at very affordable cost. The third strategy, that is the vaccination. If we see the coverage, it was 63% of newborns, they received the first dose, while 93% were covered by 3 doses, which is given at after the birth. So this target for 2019-20 was 90% and 95% respectively, but at least we are not very far off. We have to increase the coverage of birth dose. Next one. So can we fill in these gaps? The first is that we have to admit that our progress, not only our progress, even global progress is offline toward 2030 goals, and we are totally never on the road. So there is a window of action for next 2024 to 2030 for WHO, in which we should concentrate our effort again to try to eliminate the disease. This can be done by increasing the awareness, public awareness, healthcare personal awareness, and political awareness about the disease. Universal hepatitis screening. Everyone should be screened for hepatitis at least once in lifetime. We are doing at present only for antenatal care. It should be extended to everyone. Improve services for testing of pregnant women to prevent vertical transmission and improve hepatitis B immunization. So this is for hepatitis B. There are certain countries and even state in our country, that is Punjab. They have implemented this program very well. Before NBHCP was introduced, they tried different modalities to control hepatitis, and they have yield very good results. So we should learn lessons from them. Dr. Ekta will be talking about this, that how this program can be implemented in a decentralized manner. Decentralized for testing and treatment services. Instead of patient coming to us, we should reach the patient, we should reach the hepatitis to patient, because there is so large population in this disease. We can think of integrating viral hepatitis prevention and control activities with other public health programs like NTP, like NACO. We can go and integrate it, and also we have our programs like Ayushman Bharat, which provides universal health coverage. They should also be hepatitis B and C can also be part of that. Better linkage between testing and care is also required because many of the patients they lost follow after testing positive. So they should be properly treated once they are diagnosed. We have expanded access to hepatitis B and hepatitis C testing and care. Community engagement is required, and we have to engage affected population and the civil society. We can go to the villages, involve the sarpanch, panchayat people, and lastly, we have to look into R&D also. We have to foster innovation for impact. To current diagnostic tests, they have some limitations. We have to overcome those. We can have better tests. Some countries have even adopted self-screening tests for HCV and HPV. So patient can test it themselves like pregnancy tests. And we have to focus on new research in developing curative strategies, curative treatment for hepatitis B virus and preventive vaccine for hepatitis C virus. That's it. So it's time for action. If we miss this window of 2.4%, probably we will never be able to meet our goals of 2030. Thank you.
Thank you so much, sir, for this wonderful deliberation. Our next speaker needs no introduction. Ladies and gentlemen, it's an honor to introduce our esteemed speaker, Professor Dr. Priya Abraham. Dr. Abraham is a distinguished virologist with an illustrious career in the field of clinical virology. She has served as the director of National Institute of Virology, Pune, where she led groundbreaking research and contributed significantly to the understanding and management of viruses in India. Dr. Abraham was involved in the nation's first evaluation of the indigenous hepatitis B vaccine in late 1990s, after which India became self-reliant for this vaccine. Dr. Abraham was at forefront of India's fight against COVID-19. As the director of IIT Pune, she was instrumental in developing India's own homogeneous vaccine against COVID-19. It's remarkable achievement that has been depicted in the movie Vaccine Bomb. Her leadership and contributions during this critical period have been invaluable. Currently, Dr. Abraham is a professor in the Department of Clinical Virology at the Christian Medical College, Vellore, where she continues to inspire and mentor the next generation of virologists. Her expertise in virology is unparalleled, and her contributions have been recognized nationally and internationally. Today, we are privileged to have her share her insights on the role of genomics in understanding and managing viral hepatitis. Over to you, ma'am, Dr. Priya Abraham.
Thank you very much for that kind introduction. I will now attempt to share my slides. I hope I'm audible and my slide set is visible. Is it visible?
No, madam, yet not shared.
You cannot see it?
No, madam.
Not visible yet?
No, madam. It said me not shared yet, I think. You
Actually,
can
I'm
click
sharing
on
my
the share.
screen.
Oh, so click on the share and the PPT.
Yeah. I've actually been doing that. Shall I quickly send this to somebody there. So
Yes, yeah, that would be great, madam.
yeah,
We'll
so,
do sharing from your side.
yeah.
Instead of-
Sorry about this glitch. I've sent this to Dr. Abhishek. I'd like to thank the organizers, Professor Dr. Ashwini Agarwal, the HOD of Clinical Microbiology and Infectious Disease. I also would like to thank the chief guest, Professor Dr. CDS Katoj, Colonel Katoj, who has taken time off to be present for this second CME on viral hepatitis at AIIMS Rajkot. And I would actually thank Dr. Agarwal for having set the stage so comprehensively in this field, which would make it easier for all of us who are following after him to give our lectures. Are my slides visible? No, I can't see them.
One minute. I'm getting it loaded in the desktop.
Yes, sure.
Just one minute.
Thank you very much. Yes, I can see the slides, and thank you very much for projecting them. So I was given the mandate to speak about the role of genomics in understanding and managing viral hepatitis. This whole discipline is really a moving target where horizons are expanding constantly. But I think this is a wonderful area to understand how the viruses and the genomics of virus and the cell have such an intimate interaction which dictates the outcome of the infection. Next slide, please. I think they're projected very differently out there. Looks very different, but anyway. So yes, hepatitis A, B, C, and D have differing routes of transmission, as was already mentioned, and together they do pose a significant global problem. 96% of hepatitis deaths are caused by hepatitis B and C. The statistics were already mentioned to you. Next slide, please. Now, there are many reasons why genomics has a very important role in understanding, diagnosing, and managing viral infections. And this is where I would give you an overview with regard to all 5 hepatitis viral infections. Next, please. I think this is got, yeah. With regard to epidemiology, it is very useful in tracing outbreaks and epidemics. It gives us a good idea of the phylogeography of the virus. Phylogeography is nothing but tracing the origin and the subsequent distribution of any particular virus variant or genotype across our globe. It's also very good at understanding familial transmission. Next, please. It's helpful in detecting early infection, understanding the stage or phase of infection, detecting infection in the immunosuppressed, where the virological profile could be very different, using new molecular markers to comprehensively diagnose the presence of the virus. Next, please. Understanding the intimate interaction between host and viral genes, the genetic predispositions towards particularly carcinogenesis. Next, please. And helps in the better management of some of these chronic viral hepatitis infections, allowing us to quantitate the virus, monitor patients who have these viral infections, and look for prognostic factors that could impact on response. Next slide, please. Routine diagnosis with regard to HAV is largely devoid of genomic tools because the virus exists as a single serotype, though there are more than one genotypes that can infect human beings. And therefore, the use of IgM HAV has been a very good tool to detect acute hepatitis due to hepatitis A virus infection. However, the use of molecular tools such as HAV RNA are very good when you are suspecting unusual modes of transmission, such as parenteral transmission. And this was very well recorded about 20 years ago in hemophiliacs through the infusion of factor VIII, where they found similar or identical genetic sequences both in the factor VIII that was infused as the recipients. They found exactly the same sequences. So this is where genomics can be extremely useful to trace out the source of transmission. And also, it has been very useful in picking up outbreaks that frequently occur in high-risk key populations, such as men who have sex with men, intravenous drug users, because they are well known to have outbreaks of HAV in them. It's also very useful in detecting large outbreaks to detect the source of infection, whether it's a foodborne or a waterborne infection. And recently, there have been several very large outbreaks, particularly in South India. And typically, it is the VP3 region that is amplified. Next, please hit, yeah, VP3 region, which is amplified to do an HAV RNA PCR. Next slide, please. With regard to genomics for HBV infection, diagnostics particularly is useful in identifying the phases of HBV infection and also occult infection. Next slide, please. I'll expand. As you know, there are 5 phases of HBV infection. And if you hit on the return button, please, twice, could you hit the enter button? You can see that these 2 phases out of the 5 phases are the immune reactive and the phases where you might have antigen negative chronic hepatitis B. Hit the button, please, once again. These are the areas where diagnostics could be particularly useful. The circles in green are the times or phases at which treatment would be most effective. Next slide, please. We come back to that slide, and the HBV molecular tools have been very good in tracing nosocomial transmission. Again, historically, there has been a transmission using multi-dose anesthetic vials. Familial transmission also has been well recorded. We had a very good record here in CMC Vellore. Next slide, please. I'm sorry, this may not project very clearly, but what I'm trying to show, I wish I could use a pointer, but if you look at the very top of that organogram, on the left, at the highest level, is a mother who was HBV DNA positive. She passed on the infection to all 4 children. That's one family set. The next family set, the mother was positive, husband was negative, as also seen in the earlier set. And she passed it on to 3 of the 4 children. And the next generation passed it on to the next generation, all of them being viremic. If you look at the last window at the bottom, the mother passed it on to again 2 of her children. And the next generation passed it on to 3 of the children. And we have a sample on the baby of the second generation, where the baby was 1 year old and DNA positive. So you can actually trace transmissions. It's unfortunate in this day and age. These were families from Jharkhand who had come to CMC Vellore, and we found them all to have genotype D. Next slide, please. Genomics with HBV also sheds a lot of light on the multi-step processes involved in the initiation of HBV-related hepatocellular carcinoma, which not only involves the virus, has impacts changes on the host, and also there are other environmental factors, aflatoxin and other toxic compounds, alcohol being a cofactor, which could accelerate hepatocellular carcinoma. Next slide, please. So this is just an overview by Penot et al., where he has shown that the virus actually exerts both an indirect oncogenic and a direct oncogenic effect on the liver through integrated DNA, which will lead to insertional mutations, also a significant amount of chromosomal instability, and the covalently closed cellular DNA by generating virus proteins, particularly HBx protein and the hepatitis B surface protein, themselves can contribute to the carcinogenesis. I'll come back to this at a later point. Next slide, please. If we look at mutations in the open reading frames of the tubercular virus, the mutations in the S gene can lead to accumulation of surface antigen, which itself can activate multiple oncogenic signaling pathways. If we look at the mutations that can occur in the pre-core region, it leads to downregulation of the E antigen and immune escape, therefore dampening the immune response to the indwelling virus. And also mutations in the X gene are well known to escalate the generation of the carcinogenic process. Next slide, please. Genotyping, we know, leads to our understanding that out of the 10 genotypes of HBV, they vary in pathogenesis, progression, liver disease, E antigen seroconversion rates, mutational frequencies and response to antivirals. Geographical variation is well known, and we know that in our country, genotype D is the predominant one, followed by A and C. D itself is associated with a lot of pre-core mutations leading to E antigen negativity. There's a lot of other mutations that happen in the virus genome. C is associated with higher virulence and pathogenic potential, which we see particularly in the eastern and northeastern part of our country. Also, HB, we know today, as per the latest guidelines of the WHO, the indication to start treatment have been much simplified. If HBV DNA is equal to or greater than 2000 IU per ml, with sustained elevation above the upper limit of normal, that is an indication for starting antivirals. Also, in women in the second trimester of pregnancy, if their HBV DNA levels are above 200,000 IU per ml, they should ideally be started on tenofovir, reduce the transmission to the pregnant woman's baby. reflex DNA testing in those who are HBV positive is now highly advocated. This is a strategy intended to promote quicker linkage to care and treatment. We do know that we have drug-resistant mutations, and they particularly, I'm sorry, the slide is getting mostly cut off, but I will just speak about it. Drug-resistant mutations, we see a lot, particularly in HIV, HBV co-infected individuals, where today tenofovir is the mainstay, and we find not just the classical mutations, but a number of other mutations in these co-infected individuals, and monitoring is required in them. And in such individuals, tenofovir may have to be stopped, and you might have to add entecavir to take care of the HBV infection. Also, we do know that there are some host polymorphisms that are seen in individuals. There is a particular polymorphism seen in the long arm of chromosome 1, which is associated to have a better response, higher chance of cure with interferon-related regimens. Today, the next slide, please. The new goals for treatment for HBV, which is hardly ever achieved in a very small minority, is functional cure. And functional cure is defined as sustained, undetectable, circulating HBsAg and HBV DNA after the finite course of treatment. This, as I said, is very rarely achieved, and genomics are well underway to try and intercept many of the processes involved inside the hepatocyte as part of the HBV replication. Next slide, please. So there are at least 7 classes of drugs that are being actively pursued. We have entry inhibitors here. We also have capsid assembly modulators that intercept here. Then we have siRNAs, which are RNA inhibitors. They inhibit the transcription of mRNA into protein. Then there we have those that will have an inhibitory effect on the covalently closed circular DNA. They are defined as epigenetic modifiers, cccDNA destabilizers, cccDNA endonucleases, as well as have HBX inhibitors. You know, that's a very important protein that has a role in carcinogenesis. We have HBsAg release inhibitors, and also, of course, the nucleotide inhibitors, as well as RNase H inhibitors. So without genomics, one can hardly see the effect of these proteins in the whole process of pathogenesis. Slide, please. We now move to HCV, and we understand that in HCV, a virus which has benefited from the use of genomics right from inception. We knew HCV in the 70s and 80s be a non-A, non-B parenterally transmissible virus. It was called NA-NBH agent, and again, molecular techniques helped in its very discovery. Using complementary DNA, using randomly created primers as transcriptase on the plasma of an experimentally infected chimpanzee, they were able to take this DNA library, clone it into gamma T phage, and then express it in E. coli, and then study 1 million clones from which they were able to identify the famous complementary DNA clone, the 5-1-1, and the rest is history. So here you can see the use of genomics right from discovering an agent that couldn't be visualized. It was also genomics have been very useful as a backup to detection of HBV positivity. Today, as per WHO guidelines, if somebody is HBV positive, it warrants HCV RNA testing pronto. And if the individual is viremic, individuals have to be started on pan-genotypic treatment. Today, there are no detailed viral kinetics such as early viral kinetics at 1 month, 3 months, etc. We just look for a sustained virus response 12 weeks after completion of treatment. There are times when you might worry about putting people on pangenotypic treatment, but 95% of individuals actually respond very well to this highly effective pangenotypic antivirals, and there is no need to do a baseline virus load, look at resistance-associated substitutions, or even address with genotype. However, in those that have been previously treated, or those who are known to be genotype 1A or genotype 3, or who have cirrhosis, they are more likely to have mutations in the NS5A region of the virus genome, and then probably resistance-associated substitutions need to be looked at. Today, in our country, we are very lucky. Next slide. Next slide, please. To be able to use mainly NS5A inhibitors and a very good NS5B pangenotypic polymerase inhibitor. And we are very proud to have these antivirals at a very, very affordable rate, as Colonel Agarwal had already mentioned. And that is why treatment has become affordable. It's up to us to increase awareness and to reach the unreached, that all can benefit from this very effective treatment. Next slide, please. And this is the evolution of HCV therapy. When we started with treatment in the 1990s, the treatment success was as low as starting from single to double digits. And with time, as we improved from standard interferon to pegylated interferon, interferon with ribavirin, pegylated interferon with ribavirin, introducing a protease inhibitor, then having the first generation of direct-acting antivirals, and in today's era of the modern pan-genotypic directly acting antivirals, you can see the fantastic response to the antivirals to the against the virus. This has all been possible because genomics helped us monitor the disappearance of HCV RNA from the plasma of the infected individual as we up the ante with using better and better antivirals. Next slide, please. This is highlighting the oncogenic mechanisms related to HCV. With HCV also, there are indirect and direct oncogenic effects of the virus. The virus particularly codes for a core protein, which can deregulate the cell cycle. It can induce mutations in the P53, which is a tumor suppressor protein. It can inactivate cellular protein pathways. It can also increase telomerase activity. Other proteins such as NS3, NS4B, and NS5A can also inhibit apoptosis. It can accelerate proliferation of hepatocytes and induce also genomic instability, but much less than what hepatitis B can do. Next slide, please. Next slide. Next slide, please. So we are now moved to Delta virus, and this is a virus, thankfully, not very prevalent in our country. But if you look at the increased relative risk for cirrhosis, hepatocellular carcinoma, liver decompensation, the risk for undergoing liver transplantation, and overall mortality, the relative risks are fairly significant. So lately, next slide, please. The Chronic Liver Disease Foundation, in particularly the United States of America, have called for a new algorithm saying that we must detect the presence of HDV if present, and therefore all chronic hepatitis B individuals must undergo HDV screening in the form of IgG antibody. And if they are negative, continue to screen them because they are people at risk. But if they are positive, an HDV RNA must be done. And if HDV RNA positive, they should be started on butyrate. Unfortunately, is available in the country. We would treat our infected individuals, if there are any, on pegylated interferon. And then these individuals have to be monitored after 12 weeks. And if the virus load has not come down by more than 2 log, they need to add on pegylated interferon, continue to monitor till the HDV RNA till the HDV RNA comes down to less than 20 IU per ml. And if they have continued, if they continue to do so for 24 weeks, they can be deemed to be functionally cured for hepatitis D virus, and the antiviral drugs can be stopped. If for some reason, despite adding pegylated interferon to bufatide, the individual does not reduce the viral load, then they have to be declared as reaching a futility endpoint, and the person has to be just managed for hepatitis B. I would like to emphasize this is not yet kicked into practice in our country. I think the policymakers have realized, and we know that the prevalence of hepatitis D is very in our country. This is the page looking out for in the future. Next slide, please. To summarize, these are some of the genetic profiles of HBV, HCV, and HDV hepatocellular carcinoma, and you can see how they impact on certain host genomes and therefore leading to genomic and chromosomal instabilities and genetic instability, pushing the liver cells into becoming more and more undifferentiated and triggering the carcinoma process. Next slide, please. With regard to hepatitis E virus, though it is usually a self-limiting disease, we do know that HEV is much more genetically heterogeneous as compared to another fecal-orally transmitted hepatitis agent such as hepatitis A virus. There are 8 genotypes of this virus. 1 and 2 infect humans. In India, we have mainly genotype 1. Genotypes 3, 4, and 5 are seen in a variety of animal species, and zoonotic spillover has been reported in the West of genotype 3 and 4 from animal sources such as wild boar and pigs, deer, etc., to humans. Genotype 7 and 8 so far have not infected humans. So it is good to have an idea of the heterogeneity of this virus. Next slide, please. Next slide. In routine diagnostics, real-time PCR has been used to interrogate acute on chronic liver failure, along with IgM detection and HEV antigen detection. This has been published from our center, and it helped to increase the number of, assign the etiology of acute on chronic liver failure marginally. But the technique and an assay, good to have in your diagnostic lab. The use of HEV real-time PCR definitely enhances the specificity of your diagnosis, because IgM positivity can sometimes be relic antibody, unfortunately so. And also doing high throughput sequencing along with using specific viral enrichment processes can help you detect novel subtypes of HEV in blood donations, can help you understand quasi-species and intra-host viral diversities in those who are chronically infected. So you might find that they have resistance mutations to ribavirin, and you may have read that HEV has been even found in the compartment of the CNS with unique mutations. So this is where genomics can help in some of the not so common situations. Next slide, please. I would like to sum up that genomic techniques provide an invaluable insight into epidemiology of these infections. help us to manage patients better, and are very powerful surveillance tools, which would help us reach the unreached and reach, the very hard to reach parts of our country, so that we can at least provide vaccination for hepatitis B and very good antiviral therapy for hepatitis C, limiting the risk of such chronic infections that have very dreadful sequelae. And with this, thank you for your patient listening. I'm so sorry I couldn't project my own slides. May have been annoying to listen to me ask next slide, please. Thank you for inviting me for this talk. Thank you.
Thank you. A big round of applause for Dr. Brand. Thank you so much for this beautiful presentation. Ladies and gentlemen, AIMS Rajkot extends its gratitude by presenting token of appreciation to the speakers. May I now request Professor Dr. Colonel C.D.S. Katot sir, Executive Director, AIMS Rajkot, to kindly present a memento on behalf of the institute. I also request Professor Agarwal, Organizing Chairperson, to receive the memento on behalf of all the speakers.
Ma'am, am I visible to you?
Yes, you are,
Ma'am,
Professor Colonel.
it's a small,
Sir, please turn yourself.
and it's a small symbolic gesture of appreciation for whatever you have done and sparing the time for us.
Thank you so much.
Memento from our institute, and I'm sure you will accept it and it will reach you soon.
Thank you so much.
Thank you so much.
Thank you.
Ma'am, can you hear me? Ma'am, can you hear me?
I can hear you.
Actually, ma'am, thank you so much for this wonderful insight on the role of genomics in hepatitis. So there are a lot of questions, ma'am, but due to time limit, I will just putting one question to you. So the question is, should HBV genotype, hepatitis B virus genotype, be considered as a risk factor for hepatocellular carcinoma? Which you have already said is yes. If yes, what are the common genotypes to be considered as hepatitis B Alaska study showed genotype F to have higher incidence, which is rarely found in Indian.
Okay, and so I got the first part of your question. The audio is not very good. Irrespective of the 10 genotypes that we have, made differently, it is not required on a routine basis, simply because the use of tenofovir is an antiviral with a very high genetic barrier. So most of the time, tenofovir helps to reduce the virus load. But HBV is a kind of virus. Because of the cccDNA in the liver, you can't completely eradicate it. That's nothing to do with the genotype or the antiviral. It is the intrinsic behavior of the virus. So in a sense, it's a bit like HIV. You can suppress the virus load, but it's hard to eradicate. But some people do actually achieve functional cure.
Thank you. Thank you so much.
Thank you.
Thank you.
So, on moving forward, I would like to introduce you all to our next speaker, Dr. A. Ma'am is a professor in health, clinical virology, and nodal officer for WHO Collaborative Center on Viral Hepatitis at the IUBS, New Delhi. She is the fellow of the Royal College of Pathology, London. Ma'am has a keen interest in clinical and diagnostic virology and has been working incessantly for the past 2.5 decades. Words will fall short to describe ma'am's contribution in the field of viral hepatitis. She has to her credit several extramural research grants, both at national and international level. Ma'am has special interest in hepatic and transplant viruses. Ma'am's profound knowledge would undoubtedly captivate our audience and provide them with valuable perspective on viral hepatitis. Over to ma'am, Dr. Ekta Gupta.
Good evening. Good evening. Can you hear me? Can you hear me?
Yes, ma'am. You are audible.
It's my.
Ma'am, we can hear you.
Okay. So a very good evening to all of you. And
Ma'am, your slides are not.
my sound is not okay.
No, slides, your slides.
I have not shared my slides this year.
Okay.
Is it okay now?
Yes, ma'am, it is okay. Thank
Okay.
you.
Can you see my slides?
Yes, ma'am.
Okay. So, good evening, and I must thank the organizers, the chief guest, Dr. Katoch, and Dr. Ashwini Agarwal and Dr. Abhishek for celebrating World Hepatitis Day and bringing out such a beautiful concept of so many people. And as you all know, we are a liver center, and I bring greetings to you from a dedicated liver care facility where we are working for the past 15 years on viral hepatitis and liver disease. And so the CME which is done is very, very apt. And so happy to share Dr. Priya Abraham, who is a role model for all of us. So the topic, I hope it is clear. My audio is clear to all of you.
Yes, ma'am.
Okay, so it was a difficult topic. Global strategies and success stories in viral hepatitis elimination, though we have been working on this. But after Dr. Ashwini Agarwal's talk on what is the current scenario, I think I can speak on that, what we need to do further and what is happening at the global front. So as we are celebrating this World Hepatitis Day, and the theme this year is it's time for action. Now, so I'll cover my talk on what is this global health sector strategy, what are actually we aim is our goal, what are the actual targets we had set, and now what are the new targets which has come up for us. What is the current status of response right now? So WHO in 2024 recently gave out a report, and what are the key areas now we need to focus more, why this theme of it's time for action has come. Few success stories of few countries which have done well, and at the national level what we have done good, and at our local, our institute level what we have done, and what are the other global agencies. So just to make it as a sound like a good story to you. So what happened was that every focus was on HIV, malaria, tuberculosis. In the year 2015, the hepatitis and deaths related globally. So the first global health sector strategy came out in the year 2016 and 21, you can see, and they set few targets. It was a global sustainable goals. Wanted these infections, new infections to reduce at least 30%, deaths to reduce 10% by the year 2030, and we're already 2024. So this was what the targets were set. Each country was pushed make their program, and so was our country, and we also made National Viral Hepatitis Program, which was launched in 2018. And unfortunately, COVID came and all our targets were not achieved or partially achieved. So what were these 2030 targets which globally was laid for everyone? This was the data which was available in 2015. We were supposed to touch by 2020 these, and 2030 these. Hepatitis B vaccination, very nicely covered, but it was the prevention of mother to child, means at birth vaccination within 12 hours, which lagged drastically. We just touched 50%, 90% needs to go. For microbiologists, B and C diagnosis, you can see so poorly covered. It was just 30%, more needs. So we have to double or triple our efforts in diagnosing to reach these 2030 targets. And so is the treatment, which needs to be upscaled. So after the COVID pandemic, WHO again collated the information and they released this global hepatitis report just this year, 2024, and they assessed what is the stock of situation. At home also we do things, no, we set targets and then interim we try to know what are we doing, is it effective, not effective. We came up that still there are 254 million people with B, or more than 300 million people together with B and C. India may not top in Olympics, but here it has come at second rank in sharing the global world burden of viral hepatitis. Half of the burden is in, the very active age group, that is 30 to 50 years, 54 years old. And they are the one who land up into hepatocellular carcinoma, because they are the one where other comorbidities of liver, like fatty liver, diabetes, things are happening. Need to work on this active population. Another area was that children were not considered as a part till your 1960 to 21 strategy, and the data came out that your 12% children are actually affected with these chronic hepatitis or viral hepatitis and burden of this illness. So need to gear up your treatment and diagnostics in this population. Southeast Asia also showed a huge burden. China topping the list and India is number 2 position in the burden. Another shocking thing which came was the deaths which started occurring. We never anticipated that after so much of effort, we will not be able to control the death. So viral hepatitis mortality though fell down, but still it was 1.1 million in 2019. So it became 1.3 million. So it was slightly up, and this was shocking. So the cancer cases, the deaths were due to the cancer cases. So something wrong, means the monitoring needs to increase, because these are the virus, you give antiviral, you can stop their replication. But if they have already damaged the liver to cirrhosis and comorbidity in the form of alcoholic insult, fat insult, the cellular carcinoma or HCC still is occurring in them. So this was shocking. And that is why in 2024, only 9th April, this news item raised an alarm that please, it is also causing a lot of mortality. Here we started an agenda where we wanted to reduce the burden of infections, but we are seeing a rise in the deaths occurring. So they came up, this is the entire report, you can actually download and read, but I have simplified. They said that now we need to change our plan of action. So new actions need to be implemented. We were working on one approach, test, treat, simplified, but now more needs to be done. Because as you can see the dotted lines, if you do not change the action right now, you will reach a plateau effect. You will not reach what we wanted in 2030. This is for hepatitis B and for hepatitis C. This is clearly, they have said that if you will not take new actions right now, there will be a plateau and you will not be able to reach your 2030 targets. This is a thing which have shown that actually we have launched globally in many countries these hepatitis program, but still the diagnostic coverage and treatment coverage is poor. Like look at Southeast Asia. It is so less. Look at here, and this is 2022 report I'm speaking, despite such an aggressive campaign, such an aggressive, the Southeast Asia is not reaching to what other countries have reached. So there is something lacking and we need to upscale. So this is a recent 2024, the Global Health Sector Strategy. They came up with this, and this is a 2020 to 2030 strategy, they have said. Now, this visions that we have to end the epidemic, we have to combine three things together. That is HIV, viral hepatitis, and STIs, sexually transmitted infections. All these three have to be together. You have to deliver services, you have to generate data, you have to engage community, you do whatever now WHO says, but please, we have to end this epidemic of these three infections. So they have set a few new targets that this is a chapter on which they want that HbA/AG prevalence. Right now, we are seeing 20 per 100,000 infections. It has to be reduced to 11 and then 2. So 10 times it has to be reduced. New infections for C need to come down to 5 per 100,000. C infections in those high-risk group, those who inject drug users, should come down, and those dying from B and C also need. So they have simplified the targets again, that please work so that there are no deaths and no new infections because of hepatitis B and C. So newness. Now, they said that what we lacked is that we are not creating enough of these public awareness campaigns. You are involving the medical doctors, but in the public people, like, so why the general public or general population needs to be aware? Because what happens that hepatitis B and C, they cause infection to the liver. They do, in the due course only, they cause cirrhosis of the liver, which ultimately causes HCC. But now it has come up that liver gets insulted by alcohol, by fat, by diabetes. So it's a metabolic syndrome. Now, if your infection is detected when the liver is already cirrhosed, it has reached to a cirrhosis. So even if you clear the virus, the cirrhosis will take its due course of time and will turn it to hepatocellular carcinoma. The research papers come up where SVR has been attained in an HCV patient and they still have HCC despite the clearance virus. So now the public awareness about getting tested during asymptomatic phase, during when your liver is healthy, and offering treatments, especially for in those where the cirrhosis has not come up, has to be upscaled. Definitely, countries have said that we require more financial resources, so needs to allocate, scale up your access to your at-birth vaccination. So within 12 hours of birth, the first dose of hepatitis B go. Then you have to increase the access of BNC testing. COVID has helped us. The silver lining of this pandemic was that it has capacitated most of the microbiology labs with the viral load gear, and so more and more viral testing. But the patient needs to be promptly informed so that he goes into the access of care and is offered treatment. You have to simplify and decentralize this. So everybody, so you don't have the testing and treatment should not remain only to gastroenterologists or specialized doctors, but it has to go down to the nurses level, to the simple medical officers level. And ultimately they are saying now that please find some curative. As Dr. Priya has mentioned, there are so many targets. So right now we are only silencing the DNA replication, but the problem of hepatitis B lies inside the liver, in CCC DNA and integrated DNA. And that is why now more options, or treat all possibility of hepatitis B, because you can't let the virus dwell inside the liver. Now, what we have done as a part of, so we are a collaborative sector, and globally, the content of ILBS was that we used to do these consultative meet on 28 July. And since 2014 till 2017, we did all the technical consultative meet, and we tried to push the country towards adoption of a national viral hepatitis program, which was launched in 2018. These guidelines needs to be updated. More needs to be adopted in terms of the Global Health Sector Strategy 2022, which has come up. So this is a data which, so our NVHCP is running very nicely in most of the states. So many centers, as already discussed by the previous speakers. And this is a prevalence data where few states really require pushing up. Delhi also, from which state I belong to, is also in third position, hepatitis B, and quite close, quite high even in hepatitis C. And so despite best of efforts of National Hepatitis Control Program, as I said, that globally, still India is at #2 position because of the huge population and the huge amount of work that needs to be done at a global level. Now, what we need to do now, the question is, first, we need to simplify and standardize the algorithm and expand it to more targeted population. So whatever diagnostic algorithm the NVHCP has given to all this, they are very, very simple. They have to be made more simpler so that the uncomplicated cases of ENC can be managed by a simple medical officer or even the nurse practitioner, if the government allows. They are able to diagnose, treat, and give treatment to them. Then this is what is the task sharing to non. So we have to move ourselves from specialized center to non-specialist. So we have to start mentoring the non-specialists, who are the medical officer, nurses, and support them in diagnosing and at least picking up who requires treatment. And somehow, if the program supports us, then a prescription of the drugs can be at a very, very decent manner. And definitely the complicated cases needs to refer to a model treatment center, but at least the non-complicated cases should be held at a decentralized manner. One has to integrate the testing. You can't do that we are just viral hepatitis center, as a co-infection often exists. So the HIV, then counseling services, harm reduction, behavioral monitoring, all those things needs to be integrated into your action plan. You have to, again, you have to decentralize and start approaching the general population, asymptomatic population, because again and again, if your liver condition is bad, it is already cirrhosed because of certain conditions, then ultimately HCC prevention is what we're targeting, which causes liver failure and death. To now shift ourselves from jaundiced cases to asymptomatic people who are coming and offer these testing services to general asymptomatic population. This was a recent study published in Gastroenterology, where again they have spoken about what are the actions and you need to do to achieve at the global level. Again, this is a repetition of what I have said, that simplification of care, simplified algorithms, improved diagnostics, innovative model are testing newer markers, generating evidence that this helps, so that a national program can adopt to these in their guidelines. Of course, financial and lessons what we have learned from the COVID-19 is what we are doing a lot of involving people, giving information to as many people as possible. So this is just the WHO, as well as these are the same as National Control Program guidelines. Our algorithms are very, very simplified. Like in hepatitis B, this is for those who don't know that we'll just look for a surface antigen. We just look for whether cirrhosis is there or not. If the liver is cirrhosed, you don't have to even go for a DNA. You can straight away administer treatment. Now, if you are HbSAg positive, and we look for two things: your age, ALT, and DNA level. So age is also there, 3 things. And if your ALT is persistently abnormal, you need treatment. Otherwise, you defer and monitor. So this is a very simplified algorithm. This needs to go to more and more people, so that even non-specialist doctors can know and can advise that, see, you have to do this and go and get a treatment. HCV is much, much simpler. Just do an antibody. All antibody, now we are saying reflex RNA testing. You don't even have to wait, do an RNA, any RNA positive has to be put on treatment. 2 simple drugs to be treated, and then you do a test after 12 weeks of treatment, wait for 12 weeks and do an SVR12. So what was, this was a simplified version. The limitation was that it was not expanded to adolescent or children age group. WHO in 2022 and 2024 has come up with new guidelines where they have incorporated the adolescent and children population. In HCV, they say that till 3, you don't have to treat or do anything. We do the testing only after 18 months of age in a child. 18 months of age, if a person is anti-HCV positive, you just wait for that child to become 3 years. Nothing harm is going to happen to him. And once beyond 3 years, you can administer the same direct acting antiviral. So this is an updation into the guidelines. Our national program has not still adopted, and our program is still limited to adult, but for children and adolescent, the newer guidelines have come up. You can read the entire document. Very soon in March 2024, WHO has also changed for the guidelines for hepatitis B, where again, this has been expanded to that is 12 to 17, where you can offer treatment. You can offer treatment under 4 conditions. If you have if the has got significant growth, DNA is more than 2000, or ALT is persistently abnormal, or there are co-infections like HIV, D, and C, then you offer the treatment. Because right now, as ma'am has also said, we give treatment under 2 conditions, stage 4 phases, second and the reactivation, 2nd and 4th phase. 2nd phase is anyone has got E antigen positive hepatitis. Now the nomenclature of hepatitis B is also changed. First phase is, which we used to call immune tolerant, is E antigen positive infection. There is no hepatitis happening here. This is the phase where till now we never used to offer treatment. And most of the children used to come under this because this is up to 25 or 30 years. But now the WHO has come up that in that phase also, if there is a significant fibrosis or the DNA persistently abnormal or there is co-infection, please go ahead and offer treatment. The another phase where we give treatment is the reactivation, that is the E antigen negative hepatitis. That is the 3rd phase, and that remains the same. So this is a change in the WHO hepatitis B and C guidelines. There are a lot of diagnostic innovations and opportunities globally which are coming up, like as we are promoting decentralized testing. So we are like in HIV, the self-testing rapid card test, and recently WHO has launched this RDT oral. It is still not in India, but this is one of the self-testing kit, because we want more and more people to test themselves at home and if come for the care and treatment. We are also pushing the labs and people who are working in viral hepatitis to start evaluating more and more point of care viral load testing devices, so that more and more can be adopted and included in not only at the global level, but also at national level. We are arranging the sample collection system also, like dried blood spot specimen to be collected, because there's an easier method for primary health centers like Northeast and all, from where the blood needs to be sent to the other lab, and so that the connectivity can be improved. We are globally, WHO is promoting and telling each government that start using integrated multi-testing disease platforms. So rather than isolated BC platform. If combined or random access systems or those multi-testing systems are there, then start incorporating them. Definitely availability of low cost, highly sensitive and specific assays should be there. If they are in the form of RDTs, good enough. Like core antigen is a very important HCV marker, but unfortunately you don't have a rapid card test available. Such assays should be made available, evaluated for the public. And definitely, as I said, markers in B and C by which you can follow a patient so that the HCC, ultimate aim is the HCC should not occur, should be evaluated. Few examples of such markers in HBV are as HBsAg quantitative. So even if your DNA becomes negative, follow the patient with the quantitative assay because that will tell you the burden of the virus inside the liver. Then assays like CCC deviation, correlated antigen or HBV RNA, which can actually tell you the progress of patient from simple HBV to an HCC should be evaluated and made available so that they are incorporated. So again, WHO is focusing that please the modules and improve the capacity at the decentralized levels, come up with the modules so that now the emphasis is that how do we monitor these patients if we have put them on an antiviral treatment. Now, as I told you, ILBS is a WHO collaborative center on liver disease and viral hepatitis. So we have been doing a lot of activities so that we are able to reach to the goals of 2030 and whatever WHO has said. We have started a lot of capacity building activities, both online and offline. We are doing training for the medical officers, microbiologists, nurses, technicians, and conducting the same kind of webinars. And one, I think I must congratulate AIIMS Rajkot that they are doing it, which is again in addition to your capacity building activities. At ILBS, we've also contributing in evaluating all the newer markers which are there so that they can be adopted by WHO or national programs like core antigen, its utility, improvised HPSAg, which can detect very, very low volume of the HPSAg so that even the occult or any smallest amount of the HPSAg can be detected and can be an important marker in monitoring. Though these assays are very expensive, they are not affordable for a public health, but such markers should be evaluated and should be made available for the program holders. We've also evaluated a lot of dried blood spot collecting methodology and tried to see that what is the utility, and we found them a good alternative injection of blood and can be used for serology as well as molecular tests and such markers. Again, I request microbiology groups also, please, you have to generate evidence so that they can be brought into the guidelines by the national program. Then simplifying and decentralized health setting up. So we did an interesting study as known as Head Start along with the Foundation in Innovation and Diagnostics, and was started in 2019, where we actually thought that how like a hub and spoke model, we can connect the sophisticated lab at ILBS to various peripheral hospitals in Delhi, and we found that it is very, very feasible. Even COVID has taught us that how feasible that sample transport and holding of so many patient footfall sites. And so here it was 15 polyclinics and 5 major hospitals. So total 20 different hospitals spread across all the 11 districts you can see of Delhi, where we connected them. And the patient used to come to these mohalla clinics and polyclinics. The sample used to be collected and transported to us. We used to do HCV RNA imaging through e-line portal, email portal. We used to send the report, and then the patient would be initiated on DA therapy. So the number of visits substantially reduced to 2 visits, only 2.4 visits of the patient. So you need to come only twice, once for the baseline investigation and second was initiated immediately. The success was that we could achieve 96% cure rate, and it was very, very high. And we actually screened about 38,000, close to 38,000 people in Delhi, and And it was a great learning experience that by just connecting one lab to several 15 in all the primary health sites in all the Delhi, we can actually bring down this and can offer treatment to so many. So such models should be implemented in each of the hospitals, and those which are having good labs connect to these primary health centers. So this is a decentralized model we have set in Delhi, and I hope other states also can use. Continuously creating a lot of awareness and advocacy, and so is everybody has started doing. We, as a WHO initiative, Amitabh Bachchan was involved because the awareness is so poor that what is hepatitis B and C. At our institute, MECOM has been taken as a brand ambassador, and we are continuously doing these events with the parliamentarians, the policymakers, because it's ultimately all this information not only should go to the doctor, should go to those who are sitting with the files and can actually allocate budgets and can change the policy of this. Another important area which needs to advocate, which ILBS is continuously doing, is discrimination. Stigma against hepatitis B, and through empathy campaign, we have started endorsing that simple problem. Need not shy, it should not be a thing to discriminate, and there is a good treatment and good regimes. And so this is our one step ahead of WHO. Special population also, we are focusing on the pregnant females, because hepatitis B is in fact, as I said, that we need to step up at birth vaccination. So these are the brand ambassadors who themselves were infected, and how they should educate other females that screening should be done, and at birth vaccination within 12 hours should be given. Another important is our website on post-exposure prophylaxis, because healthcare workers do not know much about if they get, so that's also a stigma that, oh, we should not work on hepatitis B and C, because if we have a needle prick, we don't have a post-exposure prophylaxis. So there we educate a lot of people on this. Then, since it was on strategies in global action, we need stronger community engagement. There are a lot of societies who are working, like Coalition for Global Hepatitis Elimination. There is World Hepatitis Alliance. There are special theme organization like APASL, EASL, INASL, and ASLD who are working. So we should handhold with them. Definitely, NCDC has taken up the lead in setting up the National Viral Hepatitis Control Program through the health missions, and each state health mission is doing wonderfully. So we need to upscale all these efforts together, so that more and more evidence can be generated for to reach the target of elimination of viral hepatitis by 2030. So I think I should summarize that it's a huge challenge for us to eliminate hepatitis. And one of the greatest challenges is testing. So do more and more testing, educate people on testing. And if it can be done on focus, targeting people who are at risk, then it should be great, like partners of the positive HBV, HCV, prisoners, homeless, and those who are injectable drug users, and encourage point of care viral load test platforms, so that in an affordable manner, so that more and more people can come to the cascade of care. And we have to upscale our efforts for prevention, like pick up early infections, go and screen the general population when the liver health is normal, so that at least the antivirals, when you're offering, they are in a clean liver, and not when nothing can be done or less can be done in those cirrhotic livers. So I thank you, and once again, it was a difficult topic, but just to tell you that at global front, a lot of agencies are working, and so is our commitment towards elimination of viral. Thank you.
That was a wonderful presentation. I would like to request again Professor Dr. C.D.S. Kapoor, sir, to present a memento to Dr. Ekta Gupta ma'am. I also request Professor Agarwal to receive the memento on behalf of Dr. Ekta.
Next, am I visible? Dr. Ekta, am I visible?
Yes. No, your slide is visible. I'm not seeing. You're not visible to me. I think this Department of Clinical.
Okay.
Slide, please stop the slide share.
I have stopped the
Dr.
slide.
Chintan, no, madam, not to you. To yes. Now, please, madam. Now, sir, you are visible.
Okay, ma'am, I'll take the opportunity
Yes,
to present you a token of appreciation, that is the memento of our institute. Please accept it and it will reach you soon.
Okay, thank you, sir. Thank you. Thank you.
You are welcome, ma'am. Thank you so much. Thank you, ma'am.
Thank you so much.
Yeah.
Now, I invite our next speaker, Dr. Pragya Agarwal. Ma'am is an assistant professor in the Department of Microbiology at AIMS Raipur. She has done MD in microbiology from CMC Vellore as well as a PGCC in virology from IOBS New Delhi. And she has done her FRCPAL from London. Notably, she has received a gold medal for her academic achievements. Over to you, ma'am, Dr. Pragya Agarwal.
Am I audible?
Yes, ma'am, you are audible.
So good afternoon, everyone. Respected Professor CDS Katoj, sir, Professor Ashwini Agrawal, and the organizers and delegates at this webinar. It is truly an honor for me to speak today, especially when I'm speaking on the same platform as two of my mentors, Dr. Priya Abraham and Dr. Ekta Gupta, both of whom are not just distinguished visionaries and distinguished scientists, and they are real names in field of viral hepatitis. I'm a bit overwhelmed at the moment, but then I'll try to do justice to the faith that has been shared in me by the organizers, especially Abhishek. I'll share my slides. Are my slides visible? I hope my slides are visible.
Yes, visible.
Right. So I'll be talking about the advances in diagnostic techniques for viral hepatitis. A lot of it has already been covered in the previous sessions, which makes my work much easier. The statistics have all been shared, and a viral hepatitis is unique amongst the infectious diseases in the sense that it is one infectious disease, the mortality of which has been increasing. Ekta ma'am showed this figure pretty much. The mortality because of malaria, HIV, and tuberculosis are all declining, but we must note that the mortality because of viral hepatitis has had a steady trajectory, is on the increase, and is even predicted to double by 2040. Nonetheless, with the WHO efforts, the elimination program that we are currently in, we do hope that things would become better. So these figures have already been shown. We all know that lack of diagnosis is a major gap when it comes to hepatitis B, where the world stands only when there's only 13% of those with the disease have a diagnosis. And specifically pathetic is the situation in Southeast Asia, like ma'am said, despite such tremendous efforts, the diagnostic coverage is only 2.8%. And similarly, for hepatitis C, the situation is a little better than what we have for hepatitis B, but then still not very satisfactory. 36% of the infected population across the world is diagnosed currently. Asia again, not doing very well along with the African regions. And similarly, the scenario in India has been discussed at length. A lot of efforts are being put in. A lot of technological advances are being made. A lot of innovation being played through scenario. There have been simplification of algorithms. Hepatitis C with the magical direct acting antivirals, there has been a dramatic change in scenario. The need for genotyping does not exist anymore as it used to when the treatment was interferon. Do not need to follow up at particular time points as we did need a decade ago. So only one time point follow-up has made the algorithm simplified. Testing approaches have been simplified and have been talked at length in the previous session. You have self-testing kits, you have integrated multi-disease testing platforms. Newer technologies like the point-of-care test have been developed and have been endorsed by WHO as well. We have the HCV core antigen test. We have a lot of biomarkers in hepatitis B, which I'll be talking about. The sampling approaches, dried blood spots, which has and will continue to decentralize these testing facilities, and the use of something as simple as oral fluid for testing is a very good example of how sampling approaches have been simplified. A lot of member countries of WHO, including us, have their own national programs in place, and good hand-holding, the landscape is all set to improve. So I'll talk about the viruses now, but I wouldn't going in the regular A to E sequence. I'll talk about hepatitis B first, because I feel we have a lot of newer biomarkers which have been being developed for hepatitis B. After its serendipitous discovery, a lot has happened with hepatitis B. We have numerous diagnostic markers, we have very effective assays, we have a very safe and effective vaccine, we have good treatment options, but landscape still needs a lot of development. Despite very good drugs, a major challenge when we talk about treatment of hepatitis B is the persistence of the virus, very much like HIV. Just like Priya ma'am alluded to, is persistence in the form of something called cccDNA, about which we'll talk in slides to come. And there's another form of the virus which persists, which is called, which is a subgenomic sequence that gets integrated into the human genome. And persistence of the virus in these two forms makes a sterilizing cure difficult. So, the cure which happens is a functional cure where we have sustained HBsAg loss after treatment. But then there are new therapies which are coming, which aim at sterilizing cure. But along with new therapies, what we also need are new biomarkers, which could monitor the viral and host responses very robustly. So we all know about this virus, which is unique in the sense that it is a partially double-stranded DNA virus. And these are markers that we've all always read about. The surface antigen, which is the marker of infection, the anti-HBs antibody, which is protective, is generated after appearance of infection or after vaccination. The core antibody, which is positive in cases of acute infection as well as exacerbation of chronic infections. The total core antibody, which is just a marker of exposure, E antigen, which comes in pretty early, and anti-HBe antibody, and of course the marker of replication, HBV DNA, which can be tested both qualitatively and quantitatively. So we have a lot of platforms available for these markers. Surface antigen can be tested from rapid diagnostic tests to ELISA to CLIA to your verification as well, and we have a lot of robust platforms for HBV DNA as well. And when we look at the cascade of care for any hepatitis B confirmed case and for any laboratory and for their follow-up, there are a lot of phases in care of a hepatitis B positive patient, which starts from screening, testing, diagnosis, linkage to care, assessment of the liver fibrosis, treatment, monitoring of the treatment response, and of course, screening for hepatocellular carcinoma. Now, at each of these stages, we need a combination of markers that have to be tested in order to monitor and follow up the patient very closely. And the current assays which we have are all very good. They can all be used, they are all used in combination to place the patient into various stages of hepatitis B. But then, starting from the common use of HBV DNA, which shortens the window period. However, there do exist gaps in hepatitis B virus care. We need cost-effective, sensitive, and specific markers for treatment initiation. There have to be markers which can predict reactivation of the disease. There have to be markers that tell more specifically about intrahepatic events. The methods of testing are bound to be more decentralized. Point of care diagnostics is the need of the hour, and there have to be tests which prevent loss of follow-up in patients. Now, before we venture onto these new biomarkers, I want to give a little touch up on the HBV replicative cycle. The hepatitis B virus, through the sodium taurocolate co-transporting peptide receptor, it enters the liver hepatocytes, and uncoating happens, and then the relaxed circular DNA from the cytoplasm enters the nucleus, where it gets converted into the CCC DNA. Now, this CCC DNA is a mini chromosome in itself. This CCC DNA is an episomal form which serves as transcript for all, transcription template for all the viral RNAs. And that is responsible for production of a lot of RNA forms, be it the pre-core mRNA, be it the pre-genomic mRNA, be it the pre-genomic RNA, and be it the various mRNAs. So CCC DNA is the reason why hepatitis C virus persists just like HIV in our hepatocytes and serves and just stays over there. So we need markers that sort of pick up CCC DNA activity in the liver. Thereafter, continuing with the replication cycle, when the genomic RNA is out, it gets degraded, the negative sense RNA is formed. Of course, positive sense RNA is formed. Some viruses can get enveloped and they are released. Some viruses can re-enter the nucleus to form more of CCC DNA. But then there is another form of virus which is formed, which is the linear double-stranded DNA of the virus, which serves to primarily integrate into the host chromosomal DNA. Now, this is another form of the virus which stays there, and it produces surface antigen, it produces truncated viral RNAs, it produces the HPX protein. So it is these two forms of the virus that is important for the virus for it to cause persistent infections. So what we want to detect is markers for these two CCC DNA and the integrated HPX DNA. The problem in detecting the two forms per se is both of them exist only in hepatocytes. So if you want to look for them specifically, you'll have to do a liver biopsy with an invasive procedure. And not just the invasiveness, it is also hypothesized that the distribution of the hepatitis virus in liver is not uniform. So, the kind of sample which you obtain with a liver biopsy may not give you a very good representation of the distribution of the virus in the entire liver. So we need surrogate markers for detection of these two forms of the virus. Surrogate markers are very much there in place. Surface antigen quantitatively, there's something called hepatitis B correlated protein quantitation of the E antigen, and of course HBV RNA, which can be total or just the pre-genomic RNA, and are the different markers which we have. There exist assays for quantitation of the CCC DNA in liver biopsy samples, but then another inherent problem with these markers, with this assay, is that it is sort of compromised because of the presence of other HPV DNA intermediates which coexist in the infected hepatocytes. So they compromise with the specificity of these assays. Assays are in place for detection of the integrated DNA as well, but then we do not have any commercial assays for that. So despite being a virus with such a small genome, there are a whole lot of markers which we have hepatitis B virus. The current markers are definitely good. The intrahepatic markers would be the best, but they are compromised by the invasiveness sample that is needed. And it is the newer markers which have been developed and validated over the last decade, about which I would be talking a little more in detail. So the first marker would be HBV RNA. Since the CCC DNA is the template for transcription of all sorts of RNA, HBV RNA, be it total, be it pre-genomic, becomes the surrogate marker for transcriptional activity of the CCC DNA. And advantage of monitoring your patient with HBV RNA instead of HBV DNA would be that RNA levels decline much after HBV DNA levels. So even if the patient has turned HBV DNA negative following treatment with a nucleoside or a nucleotide analog, these pre-genomic RNA levels can remain relatively high. It is also a good marker in terms of prognosis, as it can predict your ALT flares, and it also is a very good predictor of reactivation following cessation of therapy, even in the absence of HBV detectable HBV DNA. And RNA dynamics also shows a very good correlation with loss of the surface antigen in these nucleoside or nucleotide patients. A lot of methods have been tried, a lot of platforms exist. We have the RT-PCR based platforms. We have different platforms based on different kinds of assays, hybridization based, droplet digital PCR based. And currently there are, from what I found, there are 2 commercial assays by Roche and Abbott, but both of them are research use only. We do not yet have an international WHO standards for reporting of HBV RNA, and the report is given out in terms of copies per ml. And we have to also, use these markers with a pinch of salt. This paucity of data on the robustness of marker cannot predict the liver-related complications, including cirrhosis or hepatocellular carcinoma. Another protein which has generated considerable interest is hepatitis B core-related antigen. Now, what is hepatitis B core-related antigen? So we'll just briefly look into the biogenesis of this antigen. From the pre-genomic RNA, the core protein is directly translated, right? And it is this core protein which forms the icosahedral capsid inside complete as well as empty virions. Now, the pre-core mRNA, which again comes from the CCC DNA, translates into something called a precursor protein, P20, then HBE antigen, which we know, and another small protein called the pre-core protein. So P22CR, how it is written. Now, this core-related antigen is a composite antigen that is found in serum of chronic hepatitis B patients. And this antigen consists of the core antigen, HBE antigen, and the small pre-core related protein. And since CCC DNA is the template for transcription that is happening there, this again becomes a surrogate marker for CCC DNA. This core-related antigen can distinguish between different clinical phases of chronic hepatitis B, and it has potential for distinguishing between disease which may seem negative because of a negative HBeAg versus a disease which is truly negative. This core-related antigen can also predict the risk of HCC. One downside to the use of core-related antigen is in patients who have basal core promoter or pre-core mutants, hepatitis E antigen would be negative. So there we have to interpret it carefully. There is a commercial chemiluminescence based assay which is available, which is called the Lumipulse assay, and it detects a combination of the core antigen E antibody both in the free form as well as in the antibody complexed form and the core protein in blood. And it is a good, it's good that this platform has also been validated for bright blood spots, but however, relative contribution of each component has not been elucidated. The next biomarker of hepatitis B, which is talk of the town, is quantitation of the surface antigen. And it is often said that surface antigen follows the dynamics of HPV DNA, and it is, since it is a serological marker, it is a serological alternative, cost-effective, easier to perform, less labor-intensive alternative to HPV DNA. CLIA-based assays exist, limit of detection being quite low, and ultra low level of HPS-AG, as low as 0.004 international units per ml, has been said to detect better functional cure and in fact pick up occult hepatitis B virus infection as well. Pegylated interferon-based therapy is not the therapy of choice for hepatitis B, but in those select group of patients who happen to get pegylated interferon, quantitative HPS-AG can be a valuable tool in monitoring, because pegylated interferon brings about a decline in the dynamics of quantitative surface antigen. There are other potential biomarkers. Quantitation of hepatitis B E antigen has been used to follow disease progression, to predict the seroconversion, and to determine response to some antiviral therapies. Similarly, the core antibody, the total core, has been quantified to indicate the immune response and to identify patients who are most likely to respond to therapies. And there are different isoforms of the surface antigen, the medium and the large surface protein, which have different dynamics, which do not decline at the same rate when the patient is on therapy. And the large forms of HPS-AG have been predictive of a greater risk of hepatocellular carcinoma. So these individualized isoforms of the surface antigen have also been quantified, and this again is a novel tool for management of chronic hepatitis B virus infections. So although we talk about a lot of biomarkers, the real need, as has been stated time and again, is the point of care test, which satisfy the WHO assured criteria. Largely, the point of care testing in hepatitis B has been mostly about the lateral flow assays, which we have. A lot of them are WHO pre-qualified. The hepatitis B viral load by GeneXpert is now sort of changing to serving to change the point of care molecular diagnostics. Dried blood spots have been spoken about at length. They serve to decentralize testing. They have a ease of use. They circumvent the cold chain barriers, and they are inexpensive. The transportation can happen to any distance, but yes, there's a delay in result which happens, and we have to make sure that the patient is not lost to follow up. I came across this interesting wireless electrical card sensor, which has been developed in Bangkok and published recently in Scientific Reports Nature. And they've linked it to an Android phone, and it has been used to not just detect surface antigen, but also to quantify surface antigen. So electrochemical card sensors are serving to, may serve, sort of change the face of field-based diagnostics. This particular platform showed a good linear range, showed a good limit of detection, and a good sensitivity and specificity. And yes, as has been mentioned in the previous talks, hepatitis B guidelines, which have been released earlier this year by WHO, have now advocated point of care tests as an alternative to laboratory-based HPV DNA testing. So whether the test of choice should be a point-of-care test or a laboratory-based test depends on the patient and the hospital factors. It depends upon the settings. It depends upon the laboratory that the patient is dealing with, the technical expertise, the infrastructure available in the laboratory, cost. But both of them can be used as per the need and has to be used so that testing uptake can be maximized as much as possible. A reflex testing has been introduced in the guideline. The reflex testing could be laboratory based. The lab tests a sample that is with after a sample test surface antigen positive, a viral load has to be reflexly carried out on the sample, or it can be clinic based, where after a RDT turning positive, a second sample is quickly taken from the patient and sent up for a viral load. So either form of the reflex testing must be incorporated if we want to achieve the 2020 elimination goals. So that was about hepatitis B. From hepatitis B, I move over to hepatitis D. So, although this is the smallest viral pathogen that infects humans, we very rarely talk about hepatitis D. It is often ignored. So, hepatitis D is unique in a lot of senses. It is unique because it is the only virus which has a circular DNA infecting animals. It is a defective virus. It replicates by something, by a very unique rolling circle mechanism, and it is too small to have its own protein. So the only protein which the virus, it's just some 1700 nucleotides. So the viral RNA codes only for the delta antigen, and it hijacks the machinery of the host, uses the host polymerases, and it uses the capsid proteins of hepatitis B virus to form its own envelope. Now, despite being such a small virus, it causes the most severe form, or most severe and most progressive form of viral hepatitis in humans. There have been 3 meta-analyses recently, and the estimate of prevalence of this infection have ranged from 12 million to 72 million. So there's a lot of gap, a lot of heterogeneity in the current epidemiological data, and the lack of universal testing for the antigen, or for the virus as such, which is done mostly used not the antigen but the antibody. That is the single most important reason why we underestimate the prevalence of the infection. The routes of transmission are very much the same as hepatitis B, but then IV drug users are said to be at the highest risk of infection. Hepatitis D virus can cause either a co-infection with hepatitis B virus, where it presents as acute hepatitis. The patient would the diagnostic markers would be the serum HBV DNA and the serum surface antigen, which is followed by a rise of the serum HDV RNA. Anti-HDV comes in later. HDG, or the delta antigen, is difficult to detect. It comes and stays for a very short while. And of course, IgM antibody, which is a marker of acute infection. This kind of presentation in a co-infection is usually self-limiting and it subsides. However, when hepatitis D infects a person with chronic hepatitis B, what happens is a super infection. And a super infection is diagnosed using detection of serum HDV RNA in a patient who's already positive for surface antigen and for HBV DNA. And you do not get a core IgM in cases of super infection. Again, HDV antibodies come in late. Slowly, the infection becomes chronic, which can last for months to years. The WHO 2024 guidelines, as has already been spoken by Priya, talks about testing every patient with chronic hepatitis B for hepatitis D. So the testing which is recommended is universal. Everybody with CHP should be screened for anti-HDV antibodies. If at all universal testing does not happen by any reason, we have to screen people who were born in HDV endemic countries, regions, or areas, people with advanced liver diseases who present with features that suggest HDV infection, and people who are at increased risk of infection, including the hemodialysis recipients, people with hepatitis C, the other bloodborne viruses, people who inject drugs, commercial sex workers, and MSFs. The same guideline also talks about the testing strategy. Serology for total anti-HDV should be done. And any positive serology has to be followed up with a nucleic acid test to confirm HDV viremia in the patient. The nucleic acid tests for HDV RNA, there are a lot of assays available, which are, the testing should be done using a good assay with good performance characteristics. Most of them target the ribozyme region. WHO recommends these assays should have a limit of detection of at least 100 IU per ml. Reflex testing is also recommended for hepatitis D. Now, reflex testing is there in 2 terms. Anybody who's testing hepatitis B antigen, surface antigen positive should, along with hepatitis B virus DNA, should also be tested for hepatitis D. And anybody who's testing hepatitis D antibody positive, HDV antibody positive, should also be followed up with a HDV RNA testing. So this is how we would be able to pick up more and more of hepatitis D. This is the WHO list of commercially available anti-HDV assays. ELISA-based assays as well as chemiluminescence-based assays are available, and molecular platforms are also available for hepatitis D virus with good performance characteristics. However, there are molecular point of care tests. I found this rapid point of care test for serodiagnosis of hepatitis delta virus, which is a lateral flow assay, which has been developed in Germany. It is being validated further, and it showed good performance characteristics. The sensitivity was 94%, specificity was 100%, and it showed robustness over a broad range of antibody titers. However, we do not have any molecular point of care tests for hepatitis virus. So moving over to hepatitis C virus. Hepatitis, the data has all been spoken about, so I wouldn't talk about the statistics. Unlike hepatitis B, hepatitis C is an easier virus to deal with in terms of the laboratory markers. Anti-HCV is usually the first choice of diagnosis, except in individuals who are immunocompromised or are on dialysis, where we have to opt for HCV RNA as the first test for diagnosis. Considerable attention is being given to the HCV core antigen, which follows the dynamic of the HCV RNA. So this is the algorithm for diagnosis, where we have a lot of platforms for anti-HCV antibody. We have rapid diagnostic techniques. We have all the platforms, ELISA, CLIA, ALPHA, and antigen testing. We do not have rapid diagnostic techniques, but we do have kits which detect both antigen and antibody combined and antigen alone. This has to be done in or RNA testing. Both qualitative as well as quantitative assays for RNA testing exist. Genotyping has with the genotyping testing, which should be used to increase the testing uptake, and we must ensure that every self-tested HCV reactive result is linked to further care. And very recently, WHO pre-qualifies the first self-test, the already licensed OraQuick test, with on oral capillary blood, which is marketed by OraSure Technologies. So the guidance which we have is a simplified service delivery, which has been spoken about. HCV diagnostics must include a point of care viral load. A facility must be available, and a reflex viral load testing, just like hepatitis B, should be available to improve diagnosis. And use of direct acting antivirals for treatment of all above 3 years of age. So this is the WHO algorithm which has been spoken about. Any antibody positive assay has to be followed up either with a lab-based RNA assay or a point of care RNA assay or a core antigen. When we talk about monitoring, for monitoring, RNAs have to be used either a lab-based assay or a point of care assay. There are a lot of point of care assays which have been pre-qualified by the WHO, not just the load assay, but also the expert HCV viral load assay has excellent performance characteristics. So it is these point of care assays are serving to revolutionize the face of hepatitis C. Core antigen has drawn considerable interest in the last decade as a substitute to viral load testing. So since it follows the dynamics of RNA, it decreases the diagnostic window period when you compare it with anti-HCV antibody. Antibodies appear late, whereas core antigen appears as early as the HCV RNA. It is present in the blood in three forms: in association with complete viral particles released from hepatocytes as RNA-free antigen, and in the form of antigen-antibody complexes. But we must remember that they are no doubt less sensitive than RNA. However, for confirmation of viremia, it is good enough. Dried blood spots are indispensable now if we want to increase testing uptake. And that's about hepatitis C. Hepatitis E is a leading cause of acute viral hepatitis worldwide, and the virus is no more just a virus which is restricted to the developing world. In the developing world, it presents as either as a sporadic case or in the form of outbreaks or epidemics that happen. The presentation is mostly in young adults, and it can have a severe fulminant course in pregnancy. And most of the infections are either self-limiting. Some of them can land up into acute liver failure. The presentation in the developed world is different. This difference is attributable to the difference of genotypes that are circulating in the developing versus the developed world. In the developed world, autochthonous infection is now very well recognized. A problem of the developing world is not just the zoonotic infections which they have, it is also the persistent can be found in the immunocompromised, specifically the solid organ transplant recipients. India, half of acute viral hepatitis is attributable to hepatitis E. The seroprevalence is pretty high. And not just in India, the number of reported cases from the European Union has also increased lately. Now, because of these specific entities like severe disease in pregnancy, hepatitis E being the cause of acute and chronic liver failure, because of the persistent infection in the solid organ transplant recipients, because of the extrahepatic manifestations that the virus can have, ranging from renal to neurological manifestations, and because of this threat of transfusion-transmitted hepatitis C, there has been a rekindled interest in this virus. The markers of infection of this virus are not many. HEV RNA and the capsid antigen are the first markers that become detectable in blood and the exposure, and then they persist. Anti-HEV IgM is detectable after almost 4 weeks of infection, and IgG can persist for several years. This is what happens in acute self-limiting hepatitis E infection. In patients who are immunocompromised, mostly because of solid organ transplant or because of malignancy, hepatitis E infection can land up into chronic infections. Thankfully, with the genotype that is prevalent in our country, genotype 1, chronicity hasn't been shown to be full-fledged. So genotype 1 sort of has a limited potential, if none, to cause chronic infections, but genotypes prevalent in the West can quite often lead to chronic hepatitis E virus infections. So the diagnosis in immunocompetent individual relies upon antibody tests, which make use of the recombinant ORF2 and 3 proteins, and HEV IgM is the marker of acute infection. However, the problem is assays are not very robust, and HEV IgM can show a lot of false reactivity. So an ideal diagnosis of acute hepatitis E should combine either a rising titer or should be coupled with an IgG, or it should combine HEV RNA for diagnosis. Presence of HEV IgG alone is a marker of past infection, and the currently available tests have good lower limits of detection. So the diagnostic performance is dicey, as I just said. In immunocompromised patients, the diagnosis has to be with HEV RNA. Immunoblots exist for HEV IgG, and there are rapid diagnostic tests for IgM, but the performance has to be carefully evaluated. HEV RNA detection methods can be both quantitative as well as qualitative. The quantitative methods have been used, or feces or other body fluids are gold standard for detection of active HEV infection. Antigen is again considered as an alternate to HEV RNA. However, the levels are much lower than RNA, probably because the capsid is produced in multiple isoforms, and only some of which get assembled into virions. and there are ELISA-based kits. Specifically, I think the one by Diagnostics is hugely licensed and has good performance characteristics. So, this is the algorithm for detection of HEV in the immunocompetent. So, stamping someone to be HIV positive just on the basis of an IgM alone is sort of suboptimal. So an IgM positivity should be either combined with an IgG positivity or an RNA positivity to call it a true HIV infection. And in the immunocompromised, HIV RNA, once detected, followed up HIV RNA has to be done in the blood or stool samples monthly, and only after 2 consecutive positives is the infection called chronic hepatitis or a persistent hepatitis E virus infection, which has to be treated. Moving over to hepatitis A. A is the most common form of acute viral hepatitis globally, and most of the brunt of the infection is borne by the developing countries. With hepatitis A, what we are seeing is something called an epidemiological shift in a setting like India, where there has been a consistent decline in childhood seroprevalence because of the improved sanitation facilities, because of vaccination that is becoming commoner and commoner. And this is also leading to an increasing number of older children and adolescents who are susceptible to hepatitis A. So this is creating heterogeneous pockets of exposed and susceptible individuals. Hepatitis A virus is often diagnosed by the use of hepatitis A IgM antibody, and RNA is limited for epidemiological purposes, as ma'am said, or for diagnosis in the immunocompromised. HIV IgG is a marker of exposure or protection by vaccination. So a total anti-HIV in the absence of either IgM or an abnormal ALT suggests a previous infection with HIV or is a marker of vaccination with a very successful vaccine. And again, something which I want to point out for hepatitis A is the kits may be suboptimal. There could be a lot of false reactivity. So it is very important that a reactive HAV IgM assay is interpreted in the light of the serology index and the clinical picture before reporting it out as positive. So to summarize, viral hepatitis is one of those communicable diseases for which deaths are increasing in a timely fashion if we want to achieve the WHO targets by 2030. Insufficient testing and linkage to care is becoming the bottleneck rather than access to drugs. We have good, robust drugs, but testing has to be increased manifold, and all those diagnosed have to be linked to care. The face of the diagnostics has improved. We have very good assays, very good platforms. A lot of new biomarkers are being evaluated for hepatitis B virus as such, which are non-invasive. They give more reliable information, but then none of them is sort of foolproof, comes with their own sets of weaknesses. Standardization and validation of these assays in the local population needs to be done. And the need of the hour is development and use of high quality, low cost point of care diagnostics, which meet standards for WHO pre-qualification. So we want to reach. Thank you. Thank you for a patient listening.
एक खुला हुआ है पीछे। हाँ स्टार्ट करना है या कुछ चीज का वेट कर रहे हैं? बस मुझे आवाज नहीं आ रहा है कुछ भी क्योंकि वहाँ का।
We can hear you, sir.
Okay. After listening to all the virologists, I'll just bring some clinical perspective, especially from the pediatric hepatology side. And MOB has already been made much easier by all the speakers who have spoken about the diagnostic difficulties and dilemmas in viral hepatitis prior to my talk. So I would stick to the clinical part, and thanks to the AIMS Rajkot team for inviting me for this conference here. In hepatitis B and hepatitis C gets more of prominence because of the vast number of mortality that is attributed to hepatitis B, C, and hepatitis E, and the risk of liver cancer and cirrhosis that is due to hepatitis B and C. But I would try and present the different picture, that is what viral hepatitis in children. So in children, virus can present as acute hepatitis, or in worst scenarios, acute liver failure, or as chronic hepatitis progressing to cirrhosis and HCC. Now, if we go by acute conditions, acute hepatitis is caused by several viruses, some of which are hepatotropic viruses, others are non-hepatotropic viruses. If we see the proportion of acute liver failure, there are publications over the years, and what we can see that close to 60% of acute liver failure in children are caused by viral hepatitis, and among them 87, that's close to percent is just hepatitis A. The rest 14% is comprised of HEV, parvovirus, HBV, dengue, HHV6, adeno, EBV, varicella, and others. So HAV accounts for a majority of acute liver failure in children and is the major cause of pediatric in all the pediatric liver centers and transplant centers. In contrast, viral hepatitis for a significantly lower number of chronic liver disease or chronic hepatitis, accounting for only about 1/5 to 1/4. And whereas there is a predominance of hepatitis B, hepatitis C is not that common, at least in childhood, because it's symptomatic. So they are diagnosed usually into adolescent and adulthood. Now, since hepatitis A is the most common cause of acute hepatitis or acute liver failure, is the most common in prevalence of HAV has decreased over the years. This is due to improved sanitation, maybe a vaccination. So what you can see, we did this in pediatric subjects coming to us, and this is the IgG antibody. So if IgG negative, that means the person is susceptible to hepatitis A infection. If a person is positive to IgG antibody, that means that person has either got infected previously and recovered and now has an immunity, or could be having immunity due to vaccine. The vaccination rate is very low in India, less than 5%. So we believe all positive cases, majority of positive cases are due to past infection. So if you see the numbers, almost 16% of adolescents, that is between 11 to 18 years of age, are still negative for IgG HAV. That is, 1/6 of the population between 10 to 18 years is still predisposed or susceptible to hepatitis A infection. Similarly, we extended the study into young adults and found that 10% of young adults between 18 to 30 years of age do not have the antibody to HAV and are susceptible to this infection. What does that translate to clinically? Now that translates to a higher incidence of severe infections in adults and adolescents. Now this study recently from Dr. Ekta from ILBS has shown that almost 30%, that is 1/3 of pediatric patients, 1/3 of adolescents, and 1/3 of adults develop acute liver of 1/3 of those developing symptomatic viral hepatitis A develop acute liver failure, and mortality is as high as 31% to 24% in this subgroup of adolescent and adults. So there's a high incidence of acute liver failure and there's high mortality, suggesting that the infections are becoming severe when they are presenting in adolescent or adulthood. All the types, all isolates of HAV in India were genotype 3A. So what has changed in the pattern or the endemicity is that India has gone from high endemicity. If you can make this, if you can see this diagram, this is just a representative diagram. Black means a susceptible person and gray means the person has got infected and is now immune. So what was the previous was that India was in high endemicity and majority of people used to get infected and become immune and only few people were susceptible to infection. But now with improved sanitation and slightly improved immunization coverage, what has happened is a big proportion of population is still susceptible to HIV infection during adolescent and adulthood. And so now instead of having an end pattern where HIV was throughout, we are having epidemic patterns in areas with sudden surge of HIV infection, especially during the monsoons and thereafter. The clinical and laboratory part was already covered by the previous speaker. I would just like to point out that if you need to see for viral HIV, that then the best sample is feces, because the virus is excreted in the bile and hence in the feces. So rather than doing serum HIV RNA, you should be doing fecal HIV RNA. This RNA is usually excreted in the early symptomatic phase or even in the asymptomatic phase. And the second thing that we have seen in patients being referred to us is IgG anti-HIV just being done at the peripheral centers and IgM HIV not being done. Should be corrected at most of the peripheral centers that IgM HIV is essential for the diagnosis of acute infection. IgG HIV, which develops thereafter, is actually the protective antibody which persists lifelong in hepatitis A and is not diagnostic of acute infection. What is important to note that if a child less than 5 years develops acute hepatitis A infection, only 10% develop symptoms of jaundice. Whereas if they develop it between 6 to 15 years, 40% develop symptoms. Whereas if an adult between 18 to 30 years, which I showed that are now quite susceptible to HIV infection, almost 3/4 to 85% develop symptomatic HIV infection. Now, a typical LFT, if you do in these patients with acute hepatitis, it would look something like this. High bilirubin, which is mainly conjugated, with very high AST and ALT. Now, one thing that most of the centers which are referring the patient to us miss doing is INR. So ALF, so acute hepatitis, high AST, ALT is normal. So it doesn't mean that 2000 is more severe, 3000 more severe. It doesn't depict the severity. What depicts severity is the growth hormone time and INR, which describes the synthetic function of the liver. So if the INR is increased, that means the liver is not synthesizing the coagulation factors. That means the liver is in liver failure, and these patients would require, these patients have high risk of mortality and require ICU care and possible need of liver transplantation. So INR is a must along with the liver function test whenever you see a patient with acute viral hepatitis A. What is the treatment? Anictic patient, no treatment. If the patient has jaundice, then UDCA is the only drug which we give if the patient is in acute hepatitis without liver failure. Important thing that we find is, even now we find that most of the clinicians, even the general pediatric people, are doctors are advising dietary restrictions, and now that is absolutely a wrong practice, because it's a viral infection. And basically I tend to counsel the attendants. It's difficult to counsel them because it's been ingrained in their brain that they have to restrict the diet. So I counsel them that we don't have any antivirals for this virus. So your body is going to fight the your body's immune system is going to fight the virus. So you have to give all that the child is asking. So dietary restriction should not be there. That is something to be emphasized. What we find is that because of severe dietary restrictions, most of the children are severely malnourished, losing weight acutely, and then going into a liver failure and not doing as well. The second thing is, many of them are receiving several alternative medicines, which can cause further injury to the liver and cause liver failure. So strict instructions on no alternative medicines in hepatitis A. If the patient goes into acute liver failure, that is INR is increased, then the survival is only 60%, 30%, and about 10% receive liver transplantation. This is the data from our center, and this data is almost similar in all the national and international centers which are having liver transplantation program. Now, how about deciding about LT? We have developed a model which is called a PEDS HAV model. In that, we see three things: the INR more than 3.1, the interval from jaundice to encephalopathy. If it is longer, the patient has worse outcome, and the patient has higher grades of hepatic encephalopathy. If 2 out of these 3 criteria are met, we prepare the patient for liver transplantation, and this model has been accepted and is now incorporated in the Indian Society of Pediatric Gastroenterology Hepatology Guidelines for management of pediatric hepatitis A. Coming to hepatitis E, it is less common. In last 12 years, we have seen 240 acute liver failure due to hepatitis A and more than 1,000 acute hepatitis due to hepatitis A, whereas our last hepatitis E we saw was 1 year back. So hepatitis E is definitely very uncommon. We test all patients for HAV and HEV IgM, and we only get hepatitis A over the last 1 year at least. It has a longer incubation period. Co-infection can be present, hepatitis A and E, where the patient can have 2 episodes of like relapsing jaundice. Hepatitis C is more common in young adults and adolescents, but yes, again, it is just a textbook thing. If you see the practical, the most recent papers from ILBS, from worldwide, the Indian centers, you will find that the acute liver failure, the most common virus in even in adults is hepatitis A, almost 90%, and only 10% is HEV. Pregnant females, again, this is, I think, yes, if HEV develops in pregnant females, it can lead to a severe form of acute liver failure leading to high mortality. But again, it is not that common as has been described in MCQs of PG entrances or in textbooks. So coming to the diagnosis, it was covered by the previous speaker. Yes, IgM HEV is the diagnostic. Fecal HEV RNA we don't do usually unless usually we are not doing it. IgG anti-HEV, which develops later, persists for several years, but this can actually go down and become negligible after like around 8 to 10 years. So it does not always offer lifelong protective immunity, unlike hepatitis A. One thing I missed to say in hepatitis A is hepatitis A can cause prolonged cholestasis, that is pruritus-like symptoms, which is not found with hepatitis E, and that is a clear differentiator of hepatitis A from hepatitis E. Now, recently, all of you must have heard there was a severe outbreak being reported all over the world, mainly from Europe, and then WHO took it up, and somewhere between just after COVID, there was sudden surge in everyone from Europe to Asia to America reporting about the cases of severe acute hepatitis. Now, several etiologies were put forward. Some were saying it is immune reaction to SARS-CoV-2. Some were saying it is adenovirus. And then came the AAV2, adeno-associated virus 2, which was supposed to be the most common cause in this. Now, following this, we published a paper. We looked for all these viruses in our center, but we did not find adenovirus in any of our cases. SARS-CoV-2 we found in 1, and most of our cases remained indeterminate despite the testing that we are doing. The testing which we have been following after May 22 for such cases of severe acute is after doing the first line test for A, E, B, and C, and apart from the other common causes of acute hepatitis in children, that is autoimmune hepatitis and drug-induced liver injury, these patients were labeled as severe acute hepatitis of unknown etiology, and we are testing for the common viruses like parvovirus, adenovirus, SARS-CoV-2, and HHV6. And we have found a couple of cases of parvovirus, only one adenovirus and one HHV6 since then. Now that is about acute hepatitis, which is the major chunk of patients that we are seeing in our outpatient and inpatient. Hepatitis B has definitely gone down after the improvement in immunization over the last decade or so. But still, after COVID, there was a decrease. There is some increase in cases of chronic hepatitis B coming to us. Now, this chart shows the rate of and symptomatic infections. So if a patient has vertical transmission, that is, if the child gets infection from mother, then this child is unlikely to have any symptomatic infection. So this line, the solid line, shows symptomatic infection. So almost none of the children will have symptomatic infection. In contrast, if the infection is coming after 5 years of age, that is horizontal transmission. So in that case, almost 40% of children can develop a symptomatic acute hepatitis B after this kind of infection. On the other hand, the dotted line shows the risk of chronicity. So the patients who develop vertical, the child who gets the virus through vertical transmission has 90% chance of going into chronicity, whereas the child who is getting this infection through horizontal transmission has less than 10% chance of going into chronicity. So vertical transmission is bad in this sense that it is more likely to go into chronicity and less likely to respond to our therapy. Now, the diagnostic markers, the stages are almost similar to what is there in adults, and it has been already discussed. So I'll not take much time from here, but I'll just point out that this is what we follow even in children, similar to adults, that patients are classified as HBeAg positive and HBeAg negative. In that, they are again classified as those with infection. Infection means it is normal and liver biopsy is showing minimal activity, that is histological activity index is less than 5. And hepatitis means there is activity, there is necrosis, so there is elevated AT, and liver biopsy is showing moderate to severe activity. Similarly, HBeAg negative patients will be having chronic infection or chronic hepatitis. Hepatitis again means elevated ALT or inflammation on liver biopsy. So basically this definition, this classification is important even in pediatric age group, because we are going to treat these patients who are labeled chronic hepatitis, either HBeAg positive or HBeAg negative. We are not worried about this chronic infection part where the ALT is normal and liver histology is not showing inflammation. So this is something I have tried to depict this as a natural course of pediatric hepatitis B. That is, most of the children get this infection through perinatal transmission and then go into HBeAg positive chronic infection, that is also known as immunotolerant phase. That means there will be a lot of virus, DNA is very high, but ALT is normal because immune system is not very active at any point, and the child can stay into this for a few years, or he can stay into this for a few decades, like up to 30 to 40 years at times. However, if the child gets infection through horizontal transmission, he can go into the immunotolerant phase or can directly go into immunoactive phase. Now, over time, all the children with immunotolerant phase, majority of the children, will go into immunoactive phase. The immunoactive phase means the immune system is now active and acting against the virus. So there is inflammation in the liver and ALT is elevated. Now, these patients can either go into HBeAg seroconversion, that is, they can become HBeAg negative after this, following which they can become an inactive carrier, or a few of them may become HBeAg negative chronic active hepatitis. In any case, 2 to 7% of pediatric patients every year can go on to develop cirrhosis, and about 3% every year can go on to develop decompensation of cirrhosis. The lifetime risk of developing SCC in a child who has acquired infection from the mother is around 20 to 25%. That brings us to the question, whom to treat? Now, the timing of treatment is very crucial, because if the stage can be depicted in this diagram, the immunotolerant phase is this part where DNA is high, but ALT is normal. So there is no inflammation in the liver. The immunoactive part is this part where the DNA is now going down. The immune system is active. So ALT is now elevated. And this part is the chronic inactive carrier state where DNA is also low and ALT is also normal. And there can be some flares later. So this first stage, no treatment. The third stage, no treatment. The best treatment response is likely when the immune system is active and ALT is fluctuating. So the best marker, if you have to do one test to decide treatment in HBsAg positive child, that one test would be ALT. If ALT is elevated, I would treat the child. If ALT is persistently normal, I would just leave the child and keep following him every 6 months to 1 year. So this is what has also been recommended as per the ESPHGAN European Society guide, which shows that children with persistently elevated ALT, those having moderate to severe inflammation or advanced fibrosis on liver biopsy, and those with family history of HCC are the candidates for treatment in hepatitis B. Now, what are the drugs available? This is the recent WHO guidelines, which you all are aware of. If you can see the adolescents and the children part, tenofovir and entecavir are recommended for adolescents. Tenofovir, TDF, that is tenofovir disoproxil fumarate, has now been recently in March 2024 has been approved by FDA for children as young as 2 years of age. So any child beyond 2 years of age, we are more likely to treat with TDF, and a child beyond 12 years, that is adolescent, we are likely to treat with TAF, that is right. This is TDF, this is WHO recommendation, but we are generally likely to shift to TAF because the children, the reason for which I give for this is that TDF, the antivirals you need to give to children for a much longer time. And when you give TDF for a longer time, it's likely to cause one, renal injury, two, decreased bone mineral density that we have seen over the last 10 years. And now we have shifted majority of our children, adolescents, from TDF to TAF. So TAF is the preferred drug in adolescents, and TDF and entecavir in children 2 to 11 years of age. Lamivudine, which was the drug initially, has gone out of favor mainly because there is high risk of developing of antiviral resistance as much as 70% by 5 years of usage. In contrast, the TDF and TAF have almost zero risk of resistance, and entecavir has as low as 1.2% risk of developing antiviral resistance after 5 years of use. So the preferred drugs are these three: TDF, TAF, and ETV. Now, this is just to show the data. This is from, if you have a child with normal ALT, don't even try treating him, because what we are going to get, you can see this one is our study 2018, the rest, this is a multi-centric study from USA, again a large study, and you can find that HBsAg clearance was almost close to 0% if you are treating the children with various combinations of interferon and antivirals. Similarly, you can see that HBeAg seroconversion, that is the minimum that we want in children, is as low as 9 to 15% in these children. So there is no use treating children with ALT less than with normal ALT. In contrast, if you have children with elevated AST and ALT, what you can do apart from antivirals is PEG interferon. And it has been clearly shown in several studies that using, especially our study, which showed that a combination of PEG interferon plus a nucleoside analog was superior to nucleoside analog alone. The only problem here was this study was done from 2013 to 18, at which time point lamivudine was also being used in children below 12 years of age. And that's why this could be an underrepresentation, and with better antivirals like TAF, the seroconversion rates could be better even in the NA alone group. However, PEG interferon has definitely adds especially in patients who are having elevated ALT. So in immunoactive phase, you may consider using PEG interferon in addition to antivirals. Now, the most recent recommendation, the WHO guidelines 2024 in children. In adolescents, they don't give any recommendation for children. They give recommendation for adolescents, and they say that again the same thing. If a patient has significant fibrosis, that is F3 and beyond, that is bridging fibrosis or cirrhosis. If the patient has elevated ALT, suggesting that he's having inflammation in the liver with HBV DNA more than 2000, or in presence of co-infections such as HIV, HDV, and SCV, such patient should be offered treatment. WHO recommends only oral antivirals as of now. The next part is how do we stop antivirals in children? Once you start, it's very difficult to stop. It becomes a big issue. You cannot go on for lifelong. Like in adults, it's a different game altogether. In children, at 5 years, if you're starting antivirals, you cannot go on till like 60, 65 years till the child's lifespan. So it becomes an issue. So we tried to evaluate how to stop the treatment. So if a patient undergoes SBS seroconversion, you can stop the treatment without any issue. There is no risk of relapse. However, a significant proportion will not undergo HBs seroconversion. In them, we found that the risk of relapse was only 16% if the patient had become HBeAg negative for at least 12 months before stopping of treatment. Whereas if the treatment was stopped with HBeAg still being positive, 70% had virological and relapse, that is increase in DNA to more than 2000 and increase in ALT to more than 2 times the baseline, which was at the time of stopping therapy. So at least the patient has to at least become HBs negative, or if not, at least HBeAg negative, then you can consider stopping therapy in these children. Coming to the other part is the family screening. How should we do family screening? So when you get an adult with HBsAg positive, all the members of the family, including all the children, should be tested for these 3 things. HBsAg to detect whether the child is currently infected or not. Total anti-HBc has already been described previously, which indicates either present or past infection. So this is important, especially in the family. Like if you get a child with HBsAg positive, you test his mother. The mother's HBsAg is negative, but the mother's total anti-HB core is positive. Now that may indicate that the mother was positive previously and has now cleared the virus, and may suggest that the child may have acquired infection through vertical transmission. Third part, the most important part, is you should always test for anti-HBs titer, which indicates immunity. If it is less than 10, we usually give 3 doses of hepatitis B vaccine to these children. And if it is between 10 to 100, we tend to give 1 single extra booster dose of hepatitis B vaccine. So always test these 3 things when doing a family. Restrict yourself to just HBsAg. Coming to the last part, that is SCV. We all know that the most common route of transmission is in children is through mother to child transmission. And this diagram shows why the testing should be done at 18 months, because the maternal antibody goes down and almost becomes negligible by 18 months. And the parent's own antibody against the virus, anti-SCV antibody, titers are quite high by 18 months. So 18 months is the cutoff beyond which the testing for anti-HCV is usually recommended in children who have born to mothers with HCV infection. Testing before that is anyways not useful, because the drugs are not approved for children less than 3 years of age, and around 25 to 40% anyways clear their infection without treatment. So it's not much useful to test them before this. So any child born to women, testing is usually recommended using antibody-based test after 18 months of age. SCV RNA testing can be done prior to this, but is not recommended. You are anyway not going to treat the child, so no purpose in that. And children who are anti-SCV positive after 18 months of age should be tested for SCV RNA at age 3, because the drugs are FDA approved only after 3 years of age. And there is a chance of spontaneous SCV clearance before 3 years of age. So those children who remain HCV RNA positive after 3 years of age can be treated with the pan-genotypic drugs like sofosbuvir, velpatasvir, that is available in India, or sofosbuvir, ledipasvir. So these 2 combinations are available, And these two are pan-genotypic drugs which are used in children, and the doses are described in children. So the two drugs which are, FDA approved are sofosbuvir, valproate, and sofosbuvir daclatasvir, not ledipasvir. So to summarize, acute hepatitis and acute liver failure are the commonest manifestations of hepatitis when we talk about children, and hepatitis A accounts for almost 90% of these cases. There is changing epidemiology of hepatitis A, and there is increased susceptibility of adolescents and young adults who are developing symptomatic infections and acute liver failure. Severe acute hepatitis, which has been described as an epidemic, needs extensive viral evaluation, including adenovirus, HHV6, parvovirus, and AAV2. Among the chronic viral hepatitis, hepatitis B, majority of children do not require treatment, and we have only limited drug armamentarium. The best drugs currently are tenofovir, entecavir, and peginterferon in combination with these. And hepatitis C, diagnosis can be made by antibody-based test beyond 18 months of age, but test for RNA only after 3 years of age, and treat with pan-genotypic drugs beyond 3 years of age. Thank you.
That was a very informative session. I would like to request Professor Agarwal to present a memento to Dr. Pragya and Dr. Vikrant.
Dr. Vikrant, thank you very much for very informative and practical lecture. Can you see me?
Yes. Yeah.
Okay, on behalf of our executive director, we have a small token of appreciation, our institute memento, and I would request Dr. Abhishek to receive it on your behalf and dispatch it tomorrow.
Thank you, sir. Thank you.
Please accept it. Thank you, Dr. Vikrant.
Thank you, sir.
Dr. Pragya, are you also there online?
Yes, sir.
Okay, so this is there is also a memento for you from our institute side. I would request your old SR, Dr. Mayuri, to accept it on your behalf, and so that it can be dispatched to you and you will receive it by next week.
Thank you.
Thank you very much. I would like to thank all the speakers and all the participants. We still have 250 participants with us, almost 250 participants. I would request to provide us feedback. This is the second one we have conducted, and probably next year we are planning to have it offline, and we will be having many of you with us physically. So let's see if it is our auditorium is ready. We will surely have Dr. Priya, Dr. Ekta, Dr. Vikrant, many of you we will be inviting to our institute. Thank you very much. With this, we conclude this CME. Thank you very much. Okay,
अभी बंद कर सकते हैं